Good morning and aloha. Today's date, August 10th, 2023. It's a little after 11 a.m. We're at the Hawaii State Capitol Conference Room 329. We're also coming live via video conference. I'd like to introduce myself, John Mizuno. I chair the Human Services Committee on the House side. To my right is my colleague, Chair of Health. Did you want to introduce yourself?
No, go ahead.
Representative Bellotti chairs the Health Committee, and to my left, Senator San Buenaventura chairs the Health and Human Services Committee, of course, on the Senate side. Today, we're talking about the opioid crisis and looking for healthy alternatives, safe alternatives to address this most difficult addiction that has devastated not only America, but the world. So first up, we've got the #1 doctor in the state of Hawaii on pain management specialist, our pain management specialist. It's been recognized as the Physician of the Year, not only for this year, but going back 9 years. Again, this is the authority, the top expert in the state on pain management, Dr. Gerald Garcia. Please come on up, Mr. Garcia. Doctor, and thank you for being here. We appreciate you being here.
Thank you, Chairman Mizuno, Chairman Bellotti, and Chairman San Buenaventura. Distinguished guests, good morning. Allow me to introduce myself. Thank you for the platitudes, Senator or Chair Mizuno. But I'm, at the end of the day, a physician serving both communities of the west side in Oahu, east side in Oahu, and of course on Maui, who my patients in Maui currently are very close to my heart. I haven't heard from some of them, so thoughts and prayers go out to them. Just as a side note, I'm there every Tuesdays and Wednesdays, and just this week, just so happened that I had an activity here on Oahu on Wednesday, so we left Tuesday night at 5 o'clock, and the airport was just fine, like nothing. We were talking about, getting a beer or whatever, and just waiting for a flight. And I woke up the next day, and wow, raging inferno. And, to a certain extent, I'm thankful that we dodged a bullet, so to speak, but of course, again, I have many patients, I have staff there who are living the problems and challenges that they currently face. So thoughts and prayers go out to them. Anyhow, we're here to talk about the opioid crisis. So let's look back in history. Sometime about the year 2000, 2001, the Joint Commission on Accreditation of Healthcare Organizations, or JCAHO, published a standards manual for hospitals and health institutions to follow and use as a basis for provision of care to the patient population. I remember as a medical resident that getting JCAHO accreditation for our hospital was a big deal. We would have mock inspections and everything from how many times you washed your hands to where medications were being stored was scrutinized. Hospitals needed to get a pass so that they could advertise that they are JCAHO accredited. And this would then provide some reassurance to potential patients and their families that certain standards were being met by that hospital. One of the big push by JCAHO at that time was to recognize a patient's right to appropriate management of pain. Hospitals and other medical institutions were expected to, and I quote, determine and ensure staff competency in pain assessment and management. There was a push to treat pain, however measured, as the fifth vital sign. Again, because it was the right of every patient to have adequate pain control. Of course, this was a noble effort on the part of JCAHO, but like many well-intended policies, may have contributed to the problems like the opioid crisis that we face today. Why? Because pain, especially chronic pain, is a very complex phenomenon. It can be subjective depending on how your brain and spinal cord are wired. For example, different people experience the same pain stimulus differently. If I were to cut two people with the same blade, with the exact same wound size, in the exact same location, one may cry and writhe in pain, the other may not think anything of it. It is because of these complexities in the brain and how individuals experience and react to pain differently that makes chronic pain very difficult to understand, much less treat. There is no one-size-fits-all. As such, opioids became a very tempting and convenient alternative. With the push from our regulatory organizations like JCAHO to treat pain as a fifth vital sign, something that needed to be fixed and addressed immediately, a right for every patient to have, vis-a-vis the fact that chronic pain in and of itself is a complex, poorly understood phenomenon in the medical literature with no consensus and agreed upon single treatment, medical providers found themselves caught between a rock and a hard place. And opioids at that time was the all-encompassing way to bring down a patient's pain immediately because it made temporary changes to the brain and spinal cord that almost universally brought down pain levels significantly. But there was a problem. Because the underlying cause of pain was never resolved, and the constant daily use of opioids to treat this pain, albeit temporarily, introduced a whole new set of problems that we now know come with chronic opioid use. That of dependence, somnolence, overdose, addiction, to the point that it becomes very difficult to stop taking these medications. And now, in addition to the chronic pain, patients can now develop a dependence or an addiction problem, a whole new set of problems. Multiply one patient being treated that way 1 million times across the country, and you have an opioid epidemic in your hands. Such is a place where we find ourselves now. So what can we do about it? Well, for starters, it takes certain people to have the courage to challenge the status quo, to find solutions, and to lead. Which is why I'm very thankful to all of you, especially to you, Chairman Mizuno, because this is an inconvenient truth. This is a problem. But you're not only acknowledging it, you are rolling up your sleeves, ready to work to find solutions. As mentioned, chronic pain is a complex phenomenon that is tough to treat. Varying experts with varying backgrounds will have varying opinions on the best way to treat chronic pain. A chiropractor, for example, would say manipulations will treat the pain. A primary care provider may say ibuprofen and rest will treat it. A massage therapist will say deep tissue massage will do the trick. And this is fine, because the truth is, as it currently stands, the consensus amongst medical experts is that chronic pain is best treated using the multidisciplinary approach. Not one specialty, not one modality fixes a pain sufferer. You have to approach these patients from a biological, pharmacological, interventional, psychological, complementary, rehabilitational treatment perspective to provide the best chance of success, the best possible outcome. And this is why I am here. I am one part of that multidisciplinary team. My background is interventional pain medicine. I am a physician, double board certified in anesthesiology and pain medicine. I got my medical degree from the University of Minnesota Medical School in the Twin Cities and did my residency training in anesthesiology and my fellowship training in interventional pain medicine at the Case Western University Hospitals in Cleveland, Ohio. I am what the community of physicians refers to as a pain specialist. I recognize that I am not the be-all, end-all, and that I alone cannot cure chronic pain. But my contributions help to place chronic pain sufferers on the path to adequate pain management so that they may continue to lead meaningful, productive lives despite and in spite of their pain. My role is to educate patients on the dangers of chronic opioid use and offer them non-opioid pharmacologic alternatives. I offer patients minimally invasive spinal injections, nerve blocks, rhizotomies, which stop certain nerves from causing pain. I can implant spinal cord stimulators for those with intractable pain. I can also treat cancer pain by implanting intrathecal pain pumps into the spinal cord. So patients will only require 1/100th of an opioid dose and allow that patient dying from cancer to have adequate pain control without being too zoned out to enjoy the company of loved ones and still have a good quality of life. There are many new advances in the interventional pain realm that are exciting, promising, and proven effective. The FDA has approved most of what I do and many of the new technology that is just coming about. I am excited, I am optimistic that in a few years we can beat this opioid crisis. They say that it takes a village to raise a child. Well, it also takes a village to fight this epidemic. Many of us here are part of that village. We are here to offer our services to address chronic pain through non-opioid means. It will take the cooperation of many disciplines to treat a chronic pain sufferer. We ask that you join our cause by helping to continue to make it easy for us to do our jobs. We thank you for your leadership. Thank you, and good morning.
Thank you. And Dr. Garcia, I know you have a number of patients. We appreciate you breaking away and being with us here today. So at this time, we're going to see if I have some questions from our members, and
Thank
then
you.
we'll let you go. And I do want to recognize the presence of Senator Henry Aquino.
Good
Okay, we
morning,
had a
Senator.
question from Chair San Buenaventura.
So you were talking about the intra-block?
Intrathecal pain pumps?
Intra-pain pumps.
Yes.
Okay, so my questions are, any of this covered by Medicaid of what you talked about?
Yes. All of that, the procedures that I mentioned are covered by Medicaid. The intrathecal pain pumps are a great alternative. It's interventional pain, so it's a little bit more interventional than just giving an opioid. Now, there's one patient population where opioids are appropriate, and those are the cancer patients. Because before they develop all these bad side effects from the opioids, theoretically speaking, the cancer would kill them before the opioids kill them. So it's okay to use opioids. However, the problem with cancer pain is that because of their condition, pain becomes so severe that you'll need more and more and more opioids, to the point that it doesn't just take away the pain through the spinal cord mechanism, it also affects the way patients think, and they become somnolent, they become pretty much, not functioning. And so that's hard for families because they can kind of have to balance between enjoying, their loved ones, or giving less opioids so that they can be more awake and enjoy, but then they suffer more. So the intrathecal pain pump delivers opioids into the spinal cord. It's a pump that's kind of implanted much like a pacemaker, almost like under the skin, and then there's a catheter that goes straight to the spine. And because of the delivery, the method of delivery, not by mouth, straight to the spine, the requirement to take the same amount of pain is 1/100th of whatever dose of opioids you would normally take. So then, the pain is well controlled, but the patient is awake and, more enjoying.
Okay, so
Yes,
one more question.
of course.
Okay, I know there's only one of you, but I do have constituents who are being weaned off of their opioids now, and so they are really concerned because they're being cut off as to what alternatives they have. So my question is, do you know anybody on the Big Island who will do the kind of nerve blocks that will accept Medicaid patients?
I am not sure if they accept Medicaid patients. I do, but unfortunately, I'm not in the Big Island.
Yeah.
But I know of a pain physician, an interventional pain physician, who flies from the mainland, and I don't know how frequent. Is it once a month or, to see chronic pain patients in the Big Island.
Okay, if you could send me that
Yes, yes.
information, I would
Oh,
really
and
appreciate
I should
it.
back it up a little bit. There is also somebody in Hilo who, you know, kind of like me, has a base in Oahu and then
Okay.
goes to Hilo. I don't know how frequently, but sees patients from there.
Okay, send those.
Yes, I would be
info-
happy to.
Thank you.
Dr. Garcia, could I give Senator San Buenaventura your cell number?
Yes, please.
Okay.
Yes.
I appreciate it.
Thank you.
Dr. Garcia.
Okay, let's see if we have Representative Bellotti.
Yes.
I have a variation of that question. So all of these non-opioid treatments and strategies that you discussed,
Yes.
are they typically covered in commercial plans as well?
Yes.
Okay.
So everything that I've discussed, yes. So usually if it's covered by Medicaid and Medicare, it usually follows that it'll be covered by commercial plans.
Okay, so then when people are seeking this kind of care, if they're seeking it from their primary care physician, to what degree are pain management specialists like you integrated into any kind of team
So
care?
yeah,
Or is it
that's,
something that, because you're so specialized, that while you have some really great strategies, it's actually not well used throughout the system?
yeah, I would have to say that. I think, first of all, a lot of education has to happen within the primary care physician realm because, you know, although it's, you know, all these things have been ongoing in the mainland for a very long time, I don't think in Hawaii it's a more recent development. For that reason, in fact, when I started this practice 13 years ago, when you say pain management, it was automatic, you know, oh, they will take over your opioid medications. And so a lot of education had to happen. So to answer your question about integration, it's quite disjointed, and it would be nice if there was more of an integration. I agree, that's what the multidisciplinary approach is all about. And so maybe, I don't know, just a lot of education, outreach, and I think that would help. And even like oncologists, for example, they're not aware of what we can do, really. And that's one of the hardest things is cancer pain. It's very hard to treat.
Okay, so one more final question,
course.
and it's
Yes.
a variation
No-
of it.
no problem.
So to what degree is pain management integrated into the medical school curriculum?
That's a great question. It is not very well, at least from my medical school. And, you know, pain management is a subspecialty of anesthesiology. So, you know, like you can subspecialize in something else. And so even anesthesiology in and of itself isn't very well integrated. And it's probably because if you think about it in the grand scheme of the medical world, there are, you know, kind of bigger specialties like cardiology and all these things, bigger, you know, organ systems that are discussed. And like I said, pain medicine, it's very complex. It's just like this, you know, changes in your spinal cord, changes in your brain, and then, you know, you have to do something about it. But it's actually experienced by a lot of people. At some point, 60% of us will have some type of a chronic pain issue. And, you know, the person that is the gatekeeper that makes that decision is a primary care provider, right? I have pain. And then the decision then becomes, okay, it's easy to just give opioids, you're out of my clinic, or do I, you know, go down a different path, which would take longer to fix, you'll suffer a little longer, and, you know. So it's a matter of convenience as well, I think.
Thank you. Thank you, Chair.
Thank you.
Further questions, members? Dr. Garcia, really appreciate
Thank
your time.
you. It was an honor. Thank you.
Yeah, I know you have patience, so we'll stay in touch, but thank you again for presenting
Thank
here.
you. It's my
Appreciate
pleasure.
you. Thank you.
Thank you.
Okay, next up, we've got the Department of Health. Department of Health.
Good morning, Chairman Zuno,
Good morning.
Chair Bellotti, and Chair San Buenaventura, and Vice Chair Aquino. I'm John Valera. I'm from the Alcohol and Drug Abuse Division within the Department of Health. I'm not a pain management specialist. But Deputy Director Suji apologized. She couldn't be here. She had to mobilize some of the response due to the Maui fires. And so I also had a PowerPoint today, but I tried to print it, but then a lot of funny characters came out. So I'll most likely send it to your office afterwards, Chair, if that's okay. I just had a few brief remarks about how the Hawaii Opioid Initiative has heard about alternatives to opioids over the years, and kind of give a short recap and what our current recommendations are. So the Hawaii Opioid Initiative is a sort of voluntary group, multidisciplinary team that came together around preventing trying to prevent the opioid epidemic from becoming worse as in other states. And so it launched in 2017 by the previous governor. There were over 200 volunteers involved, over 100 organizations. It had a number of work groups from treatment access, prescriber education, data decision-making, data-informed decision-making, prevention, pharmacy, education, law enforcement, and a couple of other groups that were added recently, one of which was the Native Hawaiian and substance use disorder. So a lot of the clients that we serve, we typically serve about, through our direct contracts, maybe about 5 to 7% of those who need treatment in the state, if the federal statistics are correct. But most of them, a large portion of the clients we serve identify as Native Hawaiian or part Native Hawaiian. And in 2019, the legislature introduced a Senate Concurrent Resolution 103. And so in it, it had recommendations specifically for HOI to encourage the opioid initiative work groups to include Native Hawaiian cultural intervention treatment programs, wellness plans, and holistic living systems of care, and to start to focus on it. And so a separate work group was started in 2023 to live up to honor the recommendations of that SCR. And so that work is still continuing. Mainly the work group seeks to provide opportunities for members to learn and to have access to resources, but also to bring together leaders in the Native Hawaiian community, cultural practitioners, and organizations that can identify and collaborate together, and possibly bring creative, innovative solutions to the issues we've been seeing. And we've also the work group has been they've pushed forward and supported culturally anchored trainings for each of the Hawaii Opioid Initiative work groups. There was a 2021 evaluation where we polled the members, and over half of them said they didn't receive any type of cultural competency training. And so ADAD, Department of Health, partnered with UH to develop those trainings. And that work is still in progress. As far as alternatives to opioids for pain, some of the things that we've heard, the topics we've heard over the years were acupuncture. In November 2020, there was a presentation to our work group 4, which is, I believe, the prevention work group on acupuncture. In 2020, we stood up the Hawaii Opioid website, which has a pain management section, and it has some guides that were advocated and vetted by those that were part of the work groups at the time. HawaiiOpioid.org is still there today. We're trying to migrate a lot of the content to a DOH website to have a more permanent home. And then in October 2022, prescribers and pain management, there was a training, culturally anchored training for prescribers and pain management. The training focused on pain management and culturally centered care for those clients who are Native Hawaiian. And in August 2023, there was a discussion about barriers to accessing opioid medications and pain management for chronic pain patients. There were also conversations had about forced tapering and letting go of patients from pain clinics and outdated possibly outdated education and safe prescribing practices. Topics raised in the last year, obviously fentanyl, the lack of consistent long-term reliable alternatives for pain that are covered by insurance, that these were voiced at some of our work group meetings. There was also concern that chronic pain patients lack access to their medications, especially in rural communities, that prescribers are tapering off patients, maybe perhaps unsafely, or utilizing outdated guidelines for prescribing practices, which suggests more prescriber education. And so one of the things that we want to do is try to revive the prescriber education work group and to get further input on that and what type of specific detailed trainings for prescribers we need to put together. Also discussed were that, the opioids are a valid form of pain management when monitored by a doctor. It's that whole patient-physician relationship, and that should govern all, and it should be about patient-centered care. And the pain management plan should be patient-centered as well, and it's the prescriber's responsibility to complete, those assessments to assess risk for harm, observe for overdose risk, and assess patient, pain and function regularly. And also we're looking at other programs, some federal, one through a CDC program that helps to reduce overdose risk. So if a clinic ever closes, this federal program is there to redirect the patients to other prescribers who can give them the medications that they need. Recommendations. Number one is chiefly on. I think I concur with the previous speaker that more prescriber education is needed. We had some work groups, like the prescriber work group. Right now, it's on hiatus. The folks that used to volunteer have moved on, so we need to kind of revive some of those work groups to give us, give us some feedback on. The direction, priorities, set new goals, objectives, that sort of thing, because as I mentioned, we're not pain management specialists. Also, we advocate increased access to cultural healing practices for pain, substance use treatment and recovery, and culturally anchored prevention, recognizing the historical trauma that plays a large part in the health of our communities. And as well, of course, increase naloxone availability in pharmacies in rural areas to mitigate overdose deaths, which is continuing in light of recent events. So increased access to alternatives to opioids. We favor increased access to alternatives to opioids that are reliable, ongoing, and covered by insurance. And alternatives are in need, but they need to be covered in order to be ongoing and reliable. That's the sentiment that we hear from our work groups. And also, increasing and supporting the workforce here in Hawaii to provide pain management, treatment, and recovery services. Possibly some cross-training is needed, not just within the primary care sphere, but also within the primary care and behavioral health sphere, so that they can more better work as teams and coordinate care. And also continue to provide education to the public on opioids, and also regarding illicit substances and prescription misuse, and we've heard obviously about the fentanyl. So we have a lot of rebuilding to do for the opioid initiative. And we hope we have one or two individuals as part of our work groups that have lived experience with pain. And so their input has been valuable so far. We just need to continue to get new logistical support so that the work groups can continue, the input we can collect that input, update our evaluations, our action plans, and and develop a more robust website for the public. With that, Chair, thank you so much for having me.
Thank you. I believe when I talked to Ms. Suji, she did say she may have needed to go somewhere, so I had mentioned earlier, now that you're here, if you need to go, we can ask you questions now. Would you rather us question you now if we have any?
I can take some questions.
Sure.
Chair.
Members, do you have any questions?
I'll do my best.
Okay. I think we're good. I think we're good. But thank you. Thank you so much.
Thank you, Chair.
Okay. Okay, next up, members, we've got the State Department of Human Services Office of Wellness and Resilience.
Aloha, Chair,
Good morning, Director.
Rep, and Senators. Thank you for asking us to be here. We are here to talk about the Office of Wellness and Resilience. Still in the Governor's office, will be in Department of Human Services in a couple of years. But right now,
In
we're
a
here
couple
to.
years, sorry about that.
That's okay. We're here to talk about the critical component of trauma-informed care as it plays in this issue of the opioid epidemic, looking at responding to the core issues involved in substance use and abuse, much concern around the growing number. A good example of utilizing trauma-informed care in harm reduction is an example that we're looking at right now, with looking at how to mitigate the impact of traumatic situations like what is happening right now in Maui, getting ready to utilize trauma-informed care practitioners to look at the exposure to traumatic stress, to mitigate impact of post-traumatic stress disorder, which all oftentimes leads to substance use and abuse. The trauma-informed care components recognize when substances and patients utilize substances are often utilizing to numb the pain from exposure to early childhood experiences, as well as people who are able to utilize trauma-informed care principles to reduce the exposure to ongoing impact of traumatic experiences. Trauma-informed care recognizes the realities of poverty, class, racism, social isolation, past trauma, and other social inequities that affect people's vulnerability to incapacity for effectively dealing with drug-related harm. Within our office, we are looking to improve access engagement with the healthcare system, social services, and create opportunities for people to heal from the trauma, and then acknowledge and support the substance use, mental health concerns, and experience exposure to violence by utilizing an approach that recognizes that trauma is pervasive, that it is often that drug use and abuse is often a symptom of experienced trauma. Also looking at addressing the vicarious piece that's associated with chronic exposure to listening to stories of practitioners who are providing service and supports to those who experience the opioid epidemic. Last thing I want to kind of acknowledge is the amazing impact of the availability of Narcan as it relates to first responders, which are looking at actual users as first responders in this situation. So fellow users having to respond to overdose, having availability of Narcan in hand at that moment has been seen as a critical response to saving lives. We are working currently, and as I speak, on responding to to the traumatic situations occurring right now in Maui and across the state, and mobilizing therapists and hopefully being able to focus on the trauma-informed response to mitigate the traumatic stress that's occurring right now, and hoping to do so in a way that gets ahead of any potential use of substances, maybe not immediately, but in the coming days and weeks as people are starting to realize the brevity of the situation. Turning to substances as a way to cope is going to be something that's very much on our radar, and hope that we can get the supports that we need in those communities in anticipation of some maybe not so my brain is everywhere right now. Not so healthy response to the exposure to trauma.
Thanks, Director. And Director, for the members here, are you going to be here for a few minutes, or?
We're doing a big national call at
Got it.
20
We'll do-
minutes.
we'll do
I have
questions
20
right
minutes.
now.
Yeah.
Questions for Director Hartsock?
Yeah.
Yes, Senator San Buenaventura.
Hi. Hi,
Senator.
Tia. So, I know you folks are doing the alternative therapies under the Office of Wellness and Resiliency. I was wondering whether or not, because one of the speakers is going to be talking about kratom, whether or not kratom is going to be one of those therapies you folks will be looking at as more and more patients are being weaned off of opioids.
You're talking about psilocybin and the use of.
The psilocybin, yeah, that was one of it, but I don't know whether or not we added kratom in this one.
I haven't seen that, but it doesn't mean it didn't happen. So the one that we're focusing on is the use of psilocybin
Yes.
as a mechanism to treat, as an FDA approved, and as it's coming down to the states,
Right.
looking at creating the mechanisms to and the resources to best address how practitioners will be utilizing that trauma treatment for this type of, actually it's really the psilocybin piece and the breakthrough therapies designation from the FDA is really looking at how can we utilize trauma treatments that are not necessarily Western traditional approaches, and finding the research behind that is extremely effective in addressing specifically, not severe and persistent mental illness, but addressing specifically depression, anxiety, and post-traumatic stress disorder.
Okay, thank you.
Thank you very
Yes,
much.
and we've got a question from
Yeah.
Chair Bellotti.
I have a quick, actually more comment,
Yes.
and I just want to acknowledge, Dr. Garcia did this at the beginning, but I want to just thank all of the presenters here, and Tia, you especially, and the DOH person before us, because we know that in this time, as our communities and our people in Maui are suffering so greatly, we know that you folks are really, really focused, hyper-focused on the needs of that community. I appreciate the time that you took to come here
No, absolutely.
to talk about this, because this
Super
opioid
important.
epidemic is long-standing. So my comment that I would just like you to take back, and I wish I had actually asked this to the Department of Health representative, we know that there's an advisory committee that is sitting with the governor and the mayors, and if we could get some feedback at some point, because there is a $78 million, I think,
Yes.
allocation
Yep.
that is going to be going towards programs and prevention and strategies, and we may have the NCSL person do some presentation on what are some of the options we might have, but we certainly want to be a partner in how that funds are utilized and to make sure that it's being put into the right place. So nothing for you to comment on. I know there's a lot of focus on a whole lot of other things right now, as is appropriate, but I think here on our side of this table, there's a lot of questions and concerns, and we want to be a partner in making sure that those funds are allocated and used properly.
Thank you.
Right.
I would like to get an update from Department of Health on how that working group is going. I'm not a part of that working group, so I will follow up on that. Thank you so much.
Thank you. Before we go to the next presenter, I just wanted to echo what Chair Bellotti had said. Senator San Buenaventura, all of us, we talked about it earlier. It's a very difficult time, and our hearts go out to our people on Maui. And so we hope that our prayers are with our people on Maui right now. So Thank you, members. At this point, we're going to pivot to NCSL. They're going to do a presentation, and my understanding, I believe Carmen Hansen is going to actually give us a breakdown of what Hawaii got for their settlement with the opioid settlement and some other things that what other states are doing. So, do we have NCSL up?
I see somebody there.
Oh, Carmen, yeah,
We need to get-
you have to take out the mute.
Good morning, Chair Mizuno.
Hey, good morning. Thank you for joining us. We understand that there's also going to be a workshop on opioids at the NCSL Summit next week, but we really appreciate you being here. And so you're on.
Thank you, Chair Mizuno, Chair Bellotti, Chair Buenaventura, Vice Chair Aquino, and members of the committee. I am Carmen Hansen. I'm a senior fellow here at the National Conference of State Legislatures in the Health Program. And thank you for inviting us to be with you today to present a high-level overview of state policy opioid alternatives for treating pain. And as well, before I get started with the presentation, we just wanted to share that all of our hearts and prayers are with you all from here in Denver and in our DC office as well for the folks in Hawaii, on Maui and the Big Island, and just all your first responders and everyone involved. So we just wanted to let you know that as well. Today, I'll be sharing some information collected by a team of my colleagues, and I really do mean team of my colleagues in the health program, because that's the way that we collaborate to serve the legislators and legislative staff across the country. And for those of you not familiar with NCSL, we are the bipartisan organization for state legislators and legislative staff. We provide technical assistance and other services, including trainings and conferences to support and strengthen state legislators, staff, and the legislative institution. And we track thousands of policy areas and stand at the ready to assist you when you need it. We also represent the states in DC to protect states' rights. And we also just wanted to thank Speaker Psyche for his service with the National Conference of State Legislatures, as well as give Senator Bramble there a shout out for his service to NCSL as well. And as a bipartisan organization, NCSL takes no position on this or any other state policies. Our goal is to provide a comprehensive overview of state actions to inform you for your important work in Hawaii. So today I'll provide a brief overview of opioid alternative policy options, a look at state coverage for pain alternatives through private insurance and Medicaid, as well as a review of pain as a qualifying condition for state medical cannabis programs. And we'll close our presentation with time for your questions. And we do have information on how states are spending their opioid settlement dollars. I don't have that prepared for you today, but I can make sure you get a copy of what we have about that. So as Dr. Garcia described, pain is a very, very complicated issue with complex contributing factors. And according to the American Society of Anesthesiologists, studies show that opioid treatments are only moderately effective at relieving pain for the long term and are inferior to other treatment options, including restorative sleep, cognitive or other behavioral training, and physical exercise. The most common state policy opioid alternative options to treat pain are medical or medication management, physical therapy, acupuncture, massage therapy, cognitive behavioral therapy, and medical cannabis. Less common alternative options are injections, nerve blocks, radio waves, laser or electrical signal procedures, spinal cord stimulation, as Dr. Garcia mentioned, there were those pain pumps, and there are other options as well. But we're going to be looking at those more common options today that are the more common alternatives. We can't get too far down the road of policy options without addressing how people receive medical care in the United States. And that might determine what options they have available to them for pain alternatives. You'll see here that just about 50% of Americans get their health insurance through employer-sponsored coverage. This, I think I forgot to share my slides off the top of my head. So let me do that really quick. Sorry about that. I believe you have a handout though as well of the slides. So there we go. All right. So we can't get too far down the line without talking about the policy options to see how people get their health insurance. So you'll see that about 50% of Americans get their health insurance through employer-sponsored coverage. And this is combined with the 6% that purchase coverage through the marketplace plans. And that's in the light blue little slice at the bottom of the pie. And so that means the majority of Americans are covered under commercial health insurance plans. And that group is followed by Medicaid with approximately 21%. And we'll discuss a handful of these coverage mandates, and some will apply to the marketplace and exchange plans, and some will apply to the portion of employer-sponsored plans states have authority over, with other kinds of coverage mandates, and some will apply to the Medicaid plans. And it's important to note as you consider these policy options, which types of plans or coverage the policy options apply to. And before we discuss the legislative actions to ensure coverage in the commercial markets, we want to understand when and how states have authority to regulate these private plans and when they are preempted by federal regulation because of ERISA. ERISA is the Employee Retirement Income Security Act from 1974, which governs the administration of employee benefit plans. And ERISA plans are those employer-sponsored plans that are self-funded or plans in which employers pay the claims as they occur. So these are for really large employers with typically thousands of employees. However, states can regulate the individual and small group marketplace or exchange policies, those types of plans and alternative plans like short-term plans and healthcare sharing ministries, as well as they can regulate common employer-sponsored plans, the ones that most people are familiar with. The Affordable Care Act requires all non-grandfathered health insurance plans sold on the individual and small group markets to cover the 10 essential health benefits, or EHBs, and those are listed on the slide. The categories are purposely broad, and each state can dictate their coverage specifics by selecting an EHB benchmark plan. This ensures that the use of this state benchmark plan is a floor, use this kind of benchmark as a floor to determine their coverage benefits for an individual and small group marketplace plans. Most employer-sponsored group coverage plans are not required to offer essential health benefits, but all plans cannot impose a lifetime or annual dollar limit on any covered essential health benefits. And in regards to the pain alternatives, and these are just some examples, for physical therapy, all state essential health benefit plans cover rehabilitative, occupational, and rehabilitative physical therapy, although the scope of that coverage might vary. And for example, Alabama covers 30 annual visits, Alaska's at 45, and Arizona covers 60. Again, this is just kind of a demonstration to show you the range that's out there. For acupuncture, at least 8 states' benchmark plans include acupuncture treatments, and many explicitly exclude it as well. So for example, Alaska allows 12 visits annually, and those services must be medically necessary to relieve pain, induce surgical anesthesia, or to treat a covered illness, injury, or condition. States like Colorado cover 6 annually, Montana, Oregon, and Washington are more like 12. And then you have a state like Georgia where it is not covered unless the treatment is medically necessary and appropriate and is provided within the scope of the acupuncturist's license, and the patient is directed to that acupuncturist for treatment by a licensed physician. So you'll just see that there's lots of little intricacies with these types of policies. For massage, most state benchmark plans do not reference or explicitly exclude massage therapy. And we are aware of 2 states that may cover massage therapy under certain circumstances. Connecticut excludes massage except when it's part of a prescribed physical or occupational therapy program, if that program is a covered benefit. In Florida, massage therapy services provided by a physician, massage therapist, or a physical therapist are covered when massage is prescribed, as long as it's also medically necessary, and it must include the number of treatments on that prescription, so to speak, that the patient would receive. Hawaii's benchmark plan currently states for physical therapy that physical and occupational therapy is covered when it is ordered by a physician, a physician's assistant, or an advanced practice nurse under an individual's treatment plan. And it's covered when the therapy is short-term and generally not longer than 90 days, and that physical therapy evaluations are not covered when provided by an occupational therapist. And for acupuncture and massage, the Hawaii policy currently is that people are not covered for services or supplies provided by complementary and alternative medicine providers, including but not limited to naturopathic or homeopathic care providers, acupuncturists, and massage therapists. And excuse me, all 50 states and DC maintain multiple health insurance mandates and state statute. These mandates require state-regulated health plans to cover certain benefits, things like cancer screening, primary care visits, or preventive care visits, or types of providers like a chiropractor. The scope of health insurance mandates varies greatly across the states. For example, states may specify when an insurer must provide coverage and how often that insurer must cover a service and cost-sharing requirements for enrollees. Excuse me. Unfortunately, data about coverage for physical therapists, massage, and acupuncture is a little dated. The most recent we could find was 2018. And for physical therapists, at least 18 states mandate coverage. For massage, it's at least 2 states. Acupuncture, it's at least 14 states. And the states listed here on the screen have statutorily mandated coverage requirements explicitly referencing alternative pain management therapies. And again, these are just a couple examples. It's not a comprehensive list. And as states are considering these mandates, there are some concerns that they could lead to higher premiums for consumers. And states like Colorado require the Department of Insurance to provide a fiscal review of that legislation for new health benefit mandates and for the first 5 years that mandate would be in effect, so they can see like the impact of a mandate would be over time, or at least those first 5 years. In regards to medication management, we're aware of at least one state that mandates commercial coverage for comprehensive medication management services by a licensed pharmacist, and others may cover medication management by physicians. And I just want to give a shout out to my colleague Samantha Scotti for this content, and she is available today and later for any follow-up questions on the private market side of coverage. Next, I'll cover some Medicaid coverage for alternatives to opioids for pain management. And this, excuse me, this information is provided by Catherine Costanza of our staff as well. Federal statutes and regulations require states to cover some mandatory benefits and give states the option to cover other benefits in the Medicaid program. But for all services that aren't explicitly identified as either mandatory or optional benefits, states generally have the flexibility to choose what benefits are covered and the scope and coverage of those services. In federal guidance from 2019, the Centers for Medicare and Medicaid Services communicated that it would cover non-opioid and alternative services for chronic pain management, including acupuncture, massage therapy, chiropractic care, behavioral therapy, physical therapy, and other services. The guidance cited and linked here provides an overview of different types of services and federal authorities that states can use to cover non-opioid and other alternative pain management services. And we're not going to get into the weeds of federal Medicaid authorities here, but suffice it to say that the issue here is not whether states can cover alternative pain management services, but how they do so. There's limited information on alternative pain management and Medicaid, and very few 50-state scans that identify exactly which types of services are covered. Accordingly, we're going to talk about what we do know and what we don't know. First, longstanding findings across healthcare indicate that people use more healthcare services when those services are covered by their health insurance. Secondly, we know that 40 or more states' Medicaid programs covered physical therapy, occupational therapy, and certain mental health rehabilitative services, and about half covered some chiropractic services as of 2018. And this information comes from a National Governors Association survey from 2020 and from a Kaiser Family Foundation survey of state Medicaid agencies in 2018. However, there are limitations of what we know. NCSL did not identify a 50-state survey that gives an overview of national coverage of acupuncture, massage therapy, or any other services that could potentially be covered as an alternative pain management tool. Additionally, you may have noted on the last slide that the most recent data covered services that we have is about 5 years old, so it may not reflect current coverage or trends in that coverage, but we do have a few examples of what states are doing now. In Oregon, in 2016, they introduced a new back pain policy, which added coverage for a variety of alternative pain management therapies, including chiropractic, acupuncture, yoga, interdisciplinary rehabilitation, supervised exercise, and massage therapy. The policy also simultaneously decreased or removed coverage for surgeries, long-term use opioids, and epidural steroid injections. At least one peer-reviewed study from the Journal of Internal Medicine that evaluated this back pain policy found that Medicaid beneficiaries with back pain used more alternative pain management services when Oregon started covering those services in its Medicaid program. However, the study did not evaluate how much of those effects were due to coverage of the alternative pain therapies or to the lack of coverage of the traditional therapies like opioids and surgeries. In 2019, Oregon reversed its policy on coverage of long-term opioids for neck and back pain. Utah's preferred drug list includes recommended non-opioid treatments for pain, some of which come with a 90-day supply. And for Vermont, their legislature appropriated $200,000 to a pilot program to study the use of acupuncture to treat chronic pain in Medicaid beneficiaries. And in a 2017 report about that measure, the state legislature found in the study that individuals who received acupuncture as part of that study reported a 57% decrease in the use of any medication to manage pain. And that's not just opioids, but any kind of medication, and a 59% improvement in work capacity. Missouri Medicaid implemented a set of complementary health and alternative therapy services, including limited chiropractic services, physical therapy, manual and therapeutic exercises, massage, cognitive behavioral therapy, and acupuncture. These services were made available to Medicaid beneficiaries with non-cancer neck or back pain, a traumatic injury, or chronic pain conditions. All services are coordinated by a primary care provider to treat chronic pain and reduce opioid misuse. So that covers the Medicaid portion. And don't forget that we have additional online resources that may be helpful on this topic, as well as a resource sheet that I sent before the hearing as well. And Catherine is also available today and later on for your follow-up questions regarding Medicaid coverage. So far, we've shared what commercial insurance and Medicaid programs cover, and now our third and final section is about states including pain as a qualifying condition for state-regulated medical cannabis programs. So nearly all of the 47 state, 3 territorial, and DC's medical cannabis or low THC programs include pain as a qualifying condition, but their description or definition of pain varies greatly with terms like intractable, neuropathic, severe, and chronic, and many combinations thereof, as shown on the slide. Hawaii currently includes the severe pain category in its medical cannabis program. In addition to pain, a few states and territories allow a health care provider to qualify a person no matter their chief complaint, as long as they believe that the use of cannabis might alleviate their condition. And this includes states like California, Louisiana, Massachusetts, Maine, Oklahoma, and Virginia. And as with Medicaid, there are a few things that we know and probably a lot more that we don't know, although I kept this slide pretty simple. A few things that we know about state medical cannabis programs is that including general pain or just pain increases enrollment in programs compared to those without that qualifying condition. In 2017, the National Academies of Science, Engineering, and Medicine released a report supporting the effectiveness of using cannabis to treat chronic non-cancer pain among adults. Some self-report data from patients also suggests that persons find pain relief by using cannabis. However, according to a recent Cochrane review that examined results of clinical trials assessing efficacy, tolerability, and safety of cannabis treatment for chronic neuropathic pain and the quality of evidence, they determined that the quality of evidence is pretty low to issues such as small sample sizes and participation exclusion criteria. For example, if someone has a substance use disorder that would, or another comorbidity that would not allow them to be part of the study. So this review concluded that the potential harms could outweigh the benefits of cannabis for treatment of chronic non-cancer pain. Some states experience a drop in medical program participants when adult use products are available. And it's hypothesized that some people may choose to buy in that market instead of staying on the medical side of sales because it might save them time. They don't have to have a renewal physician appointment, and it could save them money because of that, not having to pay for another appointment or for purchasing or registering for the program. But it may cost them more to purchase products because of the excise taxes that are applied to adult use sales compared to the just general sales tax that are more likely to be applied to medical products. So they'll see a savings, but depending on how many products they use, it might be in their favor. According to research published by Dr. Kayla Tormelin, medical cannabis research is difficult for a number of reasons. Primarily, there are numerous federal research requirements, including approval from multiple federal agencies. Additionally, there's the inability to accurately measure how many people are substituting cannabis for opioids, and the use of general population samples and lack of an individual level longitudinal study, and challenges disentangling the effects of state medical cannabis laws with other state laws, and methodological challenges with staggering law implementation, limited consideration of cannabis law provisions, and a lack of triangulation of multiple sources of data collection. So what we don't know far exceeds this partial list, and advocates state that cannabis use may decrease the use of opioids and therefore reduce unintentional overdose, or that cannabis may also help treat substance use disorders, and the effects of long-term use are unknown. But that what's going to happen at the federal level is also an unknown, and there's numerous other additional questions at hand. And that wraps up our content for you today, Chair Mizuno, and my colleagues and I are happy to answer any additional questions now or in the future, should you have any. So thank you very much.
Thanks, Carmen. Chairs, questions? Representative Bellotti? Chair? Chair Bellotti has a question.
No.
No, you-
I think I'm okay.
Okay. Yeah, Carmen, I'm wondering if, I know we'll be seeing you next week, but if you can email the three chairs on the other states' use of their opioid settlement monies. We just want to make sure that Hawaii is very prudent on how we spend those monies also. And I think that's it.
Chair Mizuno, I will do that, yeah.
Okay. Thank you, Carmen. Thank you so much. And we'll see you in a few days at the NCSL Summit, Indianapolis.
Thank you. Safe travels to everybody. Thank you.
Thank you. Appreciate you. Thank you. Okay, next up, we've got Health and Harm Reduction Center. Heather, I saw you come in. Thank you for being here.
Yeah, no,
Ms.
thank
West.
you, chairs. Sorry for being late. I have staff
No.
and family on Maui and
Yes.
was trying to get a hold of them. So thank you so much for the opportunity. I've been doing opioid work in Hawaii for 20 years, and this is one of the first times I can recall alternatives to pain. So this has been something I've been making a lot of noise about, and very grateful that you're doing this. To contextualize my comments, we run the statewide syringe exchange program. So for 34 years, have been working with opioid users and really seeing the challenges with addiction, and really echo Director Tia's comments about trauma. Just so you know, 90% of women who have opioid use disorder have childhood sexual trauma in their background. We also were a founder partner of the Hawaii Opioid Initiative, and for 3 years I actually chaired the prevention and education group, where we tried to we did a lot of work around prescriber education and tried to build capacity for alternatives. And then finally, I think, as all of you know, we have been the primary naloxone distribution, over 50,000 doses, and happy to report that our 30 vending machines are on island. In fact, Senator San Bonaventura is getting the bulk of them on her island, given the fentanyl there, but 30 naloxone vending machines are going to be distributed across the islands in the next 2 weeks. What we see at our we also are a buprenorphine and treatment center for opioid use disorder. While we do not do pain management, we get 5 to 10 calls a week from patients who were getting their pain medications, typically opioids, but sometimes others, and then they're just cut off and don't know where to go. We have seen dramatic increases in overdose, and the state data from Dr. Dan Galanis reflects this. Why we've done an incredible job of clamping down on overprescribing and doctor shopping using the prescription drug monitoring program. In my humble opinion, we have not done as good of a job of transitioning people who were on those medications. And so what we see at our program is multiple people going to the street to get the substances that they can no longer get through prescriptions. If you would indulge me, I just want to tell you about Joe. I met him because he was accessing our program. He was a construction worker, working very hard for his family, had 3 kids. Hurt his back in his job, was on workman's compensation, then was told he needed to go back to work. Still had a lot of pain, so he was using pain medication, but needed to pay his bills. And then his doctor got nervous about his high doses, cut him off. He felt like he had no choice because of both his dependence, his pain, and needing to keep working to go to the street. Unfortunately, he got then dependent on heroin, and that's how we found him. He lost his kids, his job, his wife. The good news is that Joe has now been 3 years on buprenorphine, which is a very effective treatment for opioid use disorder, has reunified with his family, and now has a job. we could have prevented all the Joes that we have seen that, again, have dependence or pain issues, cannot get that dealt with within the medical establishment, so unfortunately go to the street, and where we know now that fentanyl is infiltrating that supply and killing folks. And if you look at the data from the health department, as prescription opioids have gone down, overdoses, we now are seeing a huge increase in synthetic-related overdoses. So based on that and based on the calls we get, we strongly recommend that one of the ways is to do what the CDC has done. I think you've seen us go from pain as the fifth vital sign in overprescribing. Then you saw the CDC release 2011 or 2012 some very restrictive guidelines for pain management, and now they've actually released last year one saying we went too far. And we were too restrictive, and too many providers cut people off without addressing the underlying dependence, which then caused them to go to the black market, and many of them we've lost to overdose. So that's the piece around not just looking at alternatives to, which I'm also going to speak about briefly, but ensuring that our prescribers titrate down. There's very clear protocols of what people are supposed to do. Without getting into details, there's somebody who is, many of us believe was overprescribing, recently passed away. And so we inherited their patients. And the numbers they're on is not healthy, but we also know we can't send somebody with over 100 morphine equivalents of dependence without some kind of titration down. So anyway, there's a lot of recommendations on safe titration down, and even better, transitioning them to buprenorphine, which we've now, we're in a pilot project with one of the health plans to start to transition high morphine equivalent folks to the treatment, so that gets both their pain and addresses their opioid use disorder, and gets some counseling and wraparound services. So I've also seen, my husband happens to be an acupuncturist and massage therapist, and he's no longer in practice because he could not get the insurance reimbursements that were necessary to maintain his practice. I hear from many pain patients that they also can't get the coverage and don't have the out-of-pocket expenses to cover things like acupuncture, massage, physical therapy. And traditional, we really see a lot of evidence growing around traditional healing practices. Really excited to see my MedQuest partners here, who I know are working on a waiver and I believe traditional practices, whether that's, Lomi Lomi or other healing practices that might be covered. I strongly support that. And if you're not familiar with Dr. Nikki Wright's interdisciplinary pain management clinic at Waianae Coast Comprehensive, it is the best that I have seen in the islands, where it's culturally based. They address the emotional and trauma and mental health side. They also address titrating people down, getting them physical therapy, doing pain management contracts, and eventually being able to, lower their doses for people that's appropriate. And I think that kind of interdisciplinary approach, where there is mental health providers like myself, in addition to the medical providers, in addition to traditional or massage therapists, that seems to be one of the most effective ways, because people's pain, as you heard, is not just physical, it is emotional as well. And I just want to lastly be a little vulnerable and share that next week I'm going to have 28 years in recovery from injecting heroin. And as somebody who had both physical abuse and sexual abuse, I self-medicated. I've been blessed to get through my addiction and get to the other side, and that's why I do the job that I do. But there's many people like me out there that haven't had the opportunities and privilege I have had, and really appreciate your opportunity to find other ways, whether trauma responsive ways, as well as covering more modalities, so that there's more people that from the beginning can get their both physical and mental pain addressed, so they don't ever even get into opioids. So if you don't mind, just quickly, and I'm sorry I get nervous even though I know you all and talk fast. So our recommendations from our little piece of the perspective is, again, prescriber education, both around interdisciplinary pain management, including mental health providers and traditional healers, in addition to the medical practice, but also educating prescribers to titrate down, taper down, and again, have plans and not just stopping people from their medications. I cannot tell you the heartbreaking stories that I get every week from that. Secondarily is to continue to support our fabulous MedQuest and commercial plans in covering all of those pieces. Also wanted to just highlight that we're experimenting with some post-overdose successes, meaning Queens has a post-overdose program where anybody who goes into the emergency room through some work with us, they can get follow-up. And I've been also working with Jim Ireland and the EMS to try to respond right away to street-based overdoses so we can get naloxone there, but also see if pain is what's causing your use. Let's see if we can help you find other ways. And then as someone who's been doing this for a while, I was really grateful to hear you talk about the opioid settlement. We have this amazing Hawaii opioid initiative. Several of you were there from the beginning. We have not been included in the discussion at all about the opioid settlement money. And yet, as many of you know, we've been meeting for 6 years. And the work groups from law enforcement to prescribers to Native Hawaiian, there's a lot of work and expertise in that. And I would really like to see the HOI utilized as a community voice and input into the decision around the opioid settlement funds. Thank you so much for the opportunity to share. And again, forgive my quick speech. Yeah.
Heather, stay there. I'm positive we have questions. I believe Chair San Buenaventura, followed by Chair Bellotti. Yeah.
Okay, so as I mentioned earlier, a number of my constituents are those patients who are being cut off. So what I want to know, and do you have any of these written guidelines for?
Yes, I can share those with you, Senator.
Yeah, could you?
I can email them
Yes,
to
could
you.
email
Yes.
so I can send them off.
Yeah, they're from the American Society of Addiction Medicine. They have very clear guidelines on how to slowly get folks down to a different level, as well as how to induct them on buprenorphine if they're interested in that, which is also like a titration process.
Okay,
Yeah.
good. And the second thing is, I know we're going to have the Kratom people here. Have you seen any increase in any kind of ill effects for Kratom use?
No, not at all. And I'm blessed that I have been appointed to be on the psilocybin task force. So I'm hoping that we can address others, because not only Kratom, but there's been some other substances that have shown some effectiveness in some early studies for people that have opioid dependence. So I'm interested in learning more myself and hoping, as Director Hartstock said, that we can broaden the mandate to not just be around psilocybin, but other alternatives that have research.
Thank you very much.
Yeah, thank you.
I believe Chair Bellotti had a question.
Two questions. The medication-assisted treatment programs.
Yeah.
Is buprenorphine, and I'm sorry.
Yeah, is one of them.
Is one of them. What are the other?
So it's buprenorphine, or in its different permutations. So there's Subutex and things like that. Then there is methadone. And then there is naltrexone. So there's 3 different that are approved by the FDA. Naltrexone is a shot and has long acting. And then under buprenorphine, again, there's some that have formulations with that are sublingual or pills. There's now also an injection there. And then methadone. As you know, we only have 2 methadone clinics in our state. And even though the DEA has relaxed the buprenorphine prescribing guidelines as of earlier this year, I personally have not seen a huge uptake in prescribers doing it, and we're trying to actually do some work of working with other providers and doing some mentoring. My clinicians are to try to help broaden to get more prescribers for buprenorphine.
And then are those medication-assisted treatment, drugs, pharmaceuticals, are those generally all covered by our plans?
Yes, they all are covered. They are all covered by Medicaid and the commercial plans.
Okay, and the ACA marketplace plans?
Yes, that's my understanding. I'm looking at my colleagues over here. I believe that they're all covered because they are considered to be best practice.
And then
Yeah.
one last question. So is your organization a certified opioid treatment program?
No, because that is only for methadone clinics, so we only have 2. Most recently, I've been trying to start a chapter of the American Association of Treatment of Opioid Use Disorder, and been connecting with them, and they're trying to make an exception because we only have 2 methadone programs, and that's technically when OTP is the methadone, which is your CHAMP clinic, which is private and for-profit, and then Kualoha Olamau, which is a nonprofit and has a spot here, and as you know, in Hilo, and then CHAMP has local and then on Maui.
So while I appreciate you doing the work that you're doing, and we need you to continue to do that work, is there a space and a need to have more service
Yes.
providers like you, and how do we incentivize that?
Great question. So I think some is the payment reform that we're already talking about. And I know that's something that's a great example is ADAD right now covers more for methadone than the commercial plans do, but we can't use ADAD funds, meaning the reimbursement for ADAD is closer to my true cost, because we actually have a business plan. We may open a methadone clinic if I can find the seed money. So we have a whole business plan and are talking to funders because my addiction psychiatrist used to be the medical director at a previous one, and there's a great need according to Jared Radula at NED. So we are looking at that, and what we find is that because we're primarily a Medicaid population, and again, no disrespect, we know you have a lot to do, but right now, for example, ADAD pays almost a third more for methadone than the at least Medicaid plans do. And so even though I still use the Medicaid plans, that doesn't cover my true cost. Only the commercial reimbursement covers the true cost. So those of us that see a high Medicaid population sometimes have to use grants like ADAD to supplement the differences. I think I've talked with you before about the differences in that. But otherwise it is covered by the plans, just maybe not the true cost of us delivering services.
Let me, since you brought it up, do the private commercial plans?
Their rate is comparable
Higher.
and can cover, yeah.
And so then what that means is we're seeing more methadone treatment amongst the population that can afford it more.
Correct.
Is that what we're hearing?
Yeah,
Okay.
that's my understanding. With again, Department of Health and ADA, which have been very supportive, they do provide for people who don't have insurance, but they cannot provide like the wraparound, the difference, right? They can't provide the difference between what they would pay for the methadone reimbursement and what the commercial or the Medicaid plan pays, which would be kind of the ideal. I know they've looked at that, so I don't want to speak for them, but that's been one of our challenges. So when we did our business plan, we're estimating 80% Medicaid, 20% commercial plans based on our current patient population, with ADAD filling in any gaps in there. Yeah.
Okay, thank you.
And just to say how dire this is, Senator, you'll appreciate this. So BISAC, we're actually doing buprenorphine for BISAC because they can't find a single prescriber on your island that will do it. So we're doing it through telehealth with Dr. Hannah. And we're glad to do it, but that's how dire the situation is. She can't find a single prescriber on your island that could provide the buprenorphine. So my clinicians are doing it through telehealth with the clients of BISAC. And we're happy to do that, but again, we need to build the capacity here. So my understanding is reimbursement rates and then liability, because you have to get registered with narcotics enforcement, and if you're not already, so anyway, those are my understanding of the two reasons why clinicians are sometimes hesitant to start prescribing.
One last question. Heather, thank you for being here. Are there any alternatives to opioids that are not covered by Medicaid that you think should be covered?
I hate to speak for my experts over here, but I mean, you're looking at covering many of them already. So I think some of the MedQuest plans do cover some massage, some all cover physical therapy, acupuncture. Nope. See that's one area for, again, if we go to traditional treatments, I would assume acupuncture would be part of that because that's traditional Chinese medicine.
Yeah, and I think chiropractic services are not covered.
Mm-mm.
Okay.
Yep. And again, that interdisciplinary team seems to have the best evidence, where again, it's not just treating the physical pain with the medical provider, but having the mental health provider to address. Some of you heard pain is very complex, and sometimes there is cognitive behavioral therapy or mental health interventions we can do to kind of break some of the cycle between the suffering in the mind and the medications themselves. So.
Thank you, Heather. Really appreciate you.
Okay, thank you so much for the opportunity to provide some information.
Thank you. Thank you. Okay, next up, harm reduction represented by the state. Harm Reduction Services Branch. Do we have anyone from harm reduction for the state? No. Okay, thank you, Heather. Next up, we're going to go with the Department of Human Services, Medicaid. Thank you for being here.
Yeah, thank you so much for inviting us. Good to see you, chairs. My name is Meredith Nichols. I'm the assistant administrator to Dr. Moore Peterson, who's out today. She'll be back tomorrow evening. So thank you again. And I don't want to repeat sort of what was said, but I'll go through briefly some of what we wanted to share. So what we know in terms of our own covered population is about 12,000 people. That would be about 2.6% people in our Medicaid program use opioids based on data we received from 4 out of the 5 health plans. And of these, about 140, which is about 1%, take very high doses, exceeding the 120 morphine milligram or MME equivalents. And about 880, or 7.3%, take long-acting opioids, where the risk of addiction is quite higher. About 1,400, or 0.3% of the Medicaid population, is diagnosed with an opioid use disorder. I have a chart here that I know you can't see, but I'll be glad to share this with you afterwards. But it's just a chart that shows the overdose deaths in Hawaii by drug category. And looking at the chart, and specifically the narcotic deaths, we can see that, and if we think of fentanyl, heroin, and prescription opioids, that we see there's an increase in deaths recently from about 100 to 130. But when we look deep and look, kind of disaggregate that, we can see that fentanyl is the area that is really on the increase. So overall, prescription opioid deaths, and Heather addressed this earlier, as did I think Dr. Garcia, has actually decreased. But what we might be seeing is this corresponding almost doubling of the deaths due to fentanyl. We all know that meth is still a huge problem. In fact, it is the highest category of deaths in overdose deaths that we see, with about 210 people dying last year from meth overdose. Those corresponding numbers last year would be fentanyl would be 79 individuals, heroin 12, and prescription opioids 38 people. We're particularly, as are all of you, concerned with fentanyl, not only because of the disproportionate increase in addiction that we're seeing and mortality that we're seeing, but also because there's very little room for error with fentanyl. You can overdose so very easily. It's readily available. It's marketed in these fantastic rainbow colors, which impact our community members in truly horrific ways. And that we know this impact isn't just kind of that hardcore drug addict that people think of when they think about drug overdoses. It's them and also our children. In fact, we know that Hawaii Island started a narcotic task force right when a 14-year-old died from fentanyl overdose. So MQD, what are some strategies we're using to limit opioid use and prevent and treat opioid use disorder? So some preventative programs to identify problematic opioid use. Excuse me. MQD is launching a screening, brief intervention, and referral to treatment, sometimes called SBIRT for short, as a covered benefit this week statewide. In fact, John Fujii, who's here with me today, and I can call him up in a little while to answer more detailed questions about SBIRT if you're interested. He was just on Hawaii Island the day before yesterday, helping roll out this program. And the goal is, of course, to screen for that substance use in primary care settings and provide preventative interventions and or referrals to treatment. All 5 of our health plans conduct retrospective claims review process to monitor opioid prescriptions that exceed those state limitations. Also, all 5 health plans have edits in their point of sale system that alerts the pharmacy provider that the morphine milligram equivalent daily dose prescribed has been exceeded. So those are some things we're using to first identify the problematic use. And then what about preventative programs to limit access to opioids among members with that problematic use? We do require health plans to have pharmacy lock-in programs to limit access to opioids for members with a history of problematic use. And then third, in terms of the provision of medication-assisted treatment, MATs, for members with opioid use disorders, MQD has access to 442 providers across the state that prescribe or provide MAT services, and approximately 3,300 members have used MAT services at least one time between 2021 and 2022. The majority of MAT services providers are on Oahu. So that because of that, we see between 21% to 83% of our neighbor island members receiving MAT services on another island or on the continent at least one time between 2021 and 2022, meaning, again, not enough service providers on our neighbor islands results in folks having to travel for treatment. And then promising programs, and Heather talked about this a little too. As a value-added service, United Healthcare in partnership with Waimanalo Health Center, and this is just one example. I think Heather shared some, but good to recognize that this partnership with Waimanalo Health Center began a pain clinic in which they use lomi lomi and la'au lapa'au as an alternative to opioids to manage pain. They've seen clinical improvements and decreases in healthcare costs as a result, and of course, better outcomes for the people. We are looking, so MQD is in the middle of researching our 1115 waiver and drafting it, and we are looking to cover traditional Native Hawaiian healing practices, such as lomi lomi and la'au lapa'au, more broadly through that waiver. So we look forward to more community-based treatment availability moving forward. We also participate in the fantastic Hawaii Opioid Initiative, so have been members there, collaborating with everybody else. And you know, there's a great website that has all the information. I'm sure you may have seen it, but I have just a little slide on it here that I'll share later. And then finally, regarding that $78 million opioid settlement that is analogous to the tobacco settlement funds in the past. We're not a member of that council, but we do look forward to any participation that would be helpful from our MQD side and our Department of Human Services side. We hear all of you loud and clear that this is so important for our state to make sure these monies get funneled into truly effective ways to help our people. And then with that, I'll ask John if you wanted to share anything from your recent expert. You can.
Good afternoon. So, yeah, like Meredith said, I was on the Big Island on Monday and Tuesday, Hilo and Kona, and just actually head down during our education, talking to providers, and flew out from Kona on Tuesday. I didn't realize anything was wrong. I had no idea because I'm just doing my work, and you know, I wake up the next morning and on Wednesday. So, yeah, pretty crazy. But so, screening, brief intervention, referral to treatment. It's an evidence-based framework for universal STD screening. Like Meredith said, we just issued our memo last Friday. Just to clarify, like many things, we have to have our health plans in partnership with them, building their systems, building their claims payment and adjudication process, also with their prior authorizations and all that. They have to, we're working with them on a November 1st date for these services. So right now we're rolling out the information, education, sharing with providers, sharing with plans, but for a start date, November 1st. Just wanted to make sure I clarified that. It's for everyone 12 years and older, and our goal as the Medicaid division is to have 90% of 12 years and older Medicaid recipients screened at least annually by 2028. That's kind of our internal goal that we're looking at. And we have actually a specific web page on our website. We have a vanity URL, I learned that term. And that's in our memo, but it's medquest.hawaii.gov/SBIRT, SBIRT. And that's a landing page where we're going to put, we have a SBIRT manual. So we have SBIRT manual that we've been sharing. That's what we've been sharing on the Big Island. I wasn't, but our team was on Kauai yesterday, and today we had to cancel the Maui one. And there's one for Oahu tomorrow. But there's a manual that we're sharing, and people are asking questions, providers. I just want to add too, it's not just in primary care settings that you would think like doctor's office. We're wanting this to get to our, I think, 90% of our population screened once every year. We worked with Hilo Medical in Hilo and the Kona Hospital on Kona. So looking on the institutional side to get screening done in your hospital when you go for radiology in your hospital, or you have you're inpatient, or you go to the ED. We're working with our institutions to get that screening done in those places as well. Because it's not commonplace to kind of get primary care screening, but we're trying to expand out and getting reimbursement as well to follow, so that we want to encourage that behavior. And that's all I had to add for Well, just one comment on the Native Hawaiian traditional healing practices. We're focusing on Native Hawaiian, so maybe we should focus on our Chinese traditional practices too. But our eyes are not on that, so thank you, Heather. But also, different from what you might have heard for other states, you don't need to be a Native Hawaiian to get these services. So that's how we're structuring our waiver request this coming years. It's a benefit, straight up, full stop. You don't have to be Native Hawaiian, you don't have to be a certain ethnicity. So, and it's because we believe and understand that this is something that's a great alternative to what we're talking about with our opioid addictions. So that's all I had.
We may have questions.
Yeah.
I have
Chair
some very
Bellotti.
quick questions. The made a point about MAT service providers mostly are on Oahu. To what degree is the newly passed laws for telehealth services going to help you overcome the fact that most of the MAT providers might be on Oahu, or do we need to explore those areas where perhaps telehealth authorities need to be expanded so that we can ensure potentially telehealth services if we continue to have shortages of MAT service providers on neighbor islands?
So, yes, great question. It does help. It does help because there's the prescribing, as part of MAT prescribing, there's the counseling, and there's one more thing. I forget what it was. But it definitely does, it can expand, sorry?
You're in drug screen.
Drug screen, yeah. So it does help. And that's an ongoing discussion right now on the Medicaid federal level in general, because provider access, and how do you say access is good or not good because there's telehealth, as opposed to, how do you value that as opposed to someone that's on island, say, right? And is it a ratio? Accessibility. So that's, and the feds are coming out with new laws. They're actually doing lawmaking and rulemaking right now around what provider access looks like. So that's a sort of a great point, and it's unclear.
In progress, so I guess
Yeah.
I want to put it on your radar screen because we did some measures on telehealth, and I went to a conference yesterday sponsored by PBRTC up at the university, where we were kind of given an overview of all the moving pieces for telehealth policies, both at the federal level and then how we've implemented it, because we've only implemented it for a 2-year program, or until 2025. So I think as we move forward with all of these programs, I like it that you guys are in the approach of piloting. So then this comes to my next question. How much of all of this is being backed up with you folks looking at the data to identify cost savings? So for example, as you roll out SBIRT on November 1st, right? We have to be looking at the data over like a 5-year range to see if that annual screening is actually picking out people more, and then do we see some kind of reduction or cost savings? And I know it's not an easy correlation. You're not going to just see a drop because you might have expanding Medicaid populations, or with the Medicaid drop off now that we're having. So, but is Medicaid set up right now to be tracking this data that we need to see if these measures are actually working or not for cost savings?
Yeah, everything we do is data driven, right? Or we
Yeah.
try to do.
Okay.
You want to go?
No, yeah, I mean,
We'll
so
do
we're
it
in
together.
this together. We're in this together. But absolutely, and in fact, we always want to be making data-driven decisions for the simple fact of we want to know that whatever policies that we're set, the work that you want us to do, that we can come back and say, this worked. This had the impact we wanted, and at this cost. So yes, we have actuaries that look at what is spent, and we also have our health analytics office that is working alongside UH and many other, I would say all other stakeholders, to build a data platform that can really do that kind of smart data analysis, to take those kind of what may seem like separate data pools, but then look for that correlation and say, because of this, we see that. So yes, absolutely, that's in the work.
And that might be the topic for another discussion, because the health analytics, the question is do we have you guys staffed up enough in the health analytics department to do what we need to do, and are we asking the right questions?
You go
No.
ahead. I was going to say we absolutely need more people in our health analytics office. We have amazing, wonderful, mighty people, and just not enough of them to do the depth of work that's needed.
It's the ongoing work, like right now with Maui and data on Maui and what's going on and where people are. It's that, and then all the new things that we're trying to do, and just the ongoing business of running Medicaid too. There's a lot. I mean, again, we want to make sure data is behind everything we do, and the people that we have in the health analytics office are really, really top notch. They're just overwhelmed.
One last question, I promise this will be brief.
That's okay.
This partnership between UHC and Waimanalo Center, this pilot program, I love it that you guys are going to be getting a waiver to see if we can incorporate it more broadly. Is there examples of other states that have adopted this so that we know that there's a really good chance that this waiver will go through? And when I'm thinking about our Native American communities, if this is in the kind of like practice out there, so that we will likely get this kind of waiver.
Right, thank you. And it's a good question. And we've been talking with CMS about this. There are no approved traditional healing practices that are there that we can use as templates. However,
So you're breaking the ground.
we're breaking the ground. We can
Awesome.
do this. We're working side by side with Papaola Lokahi.
Okay.
It's invaluable in helping really craft what this could look like and inform, and working closely also with CMS to make sure that we're successful. And also working with different states that have high volume tribal communities, like the Dakotas, to see what it is they're doing, because everyone's working on it. We just want to be able to bring it across the finish line and make sure we get there.
And I would add that Arizona is probably the closest to getting their waiver approved.
Okay.
But I think Arizona, every other example for Native American healing practices, they're really focused on their population, right, in the tribe, right? So that's a little bit of a different. So even though there's other activities going on now around what we're thinking, very similar. If you could look at it from afar, if you drill down on it, ours is a little different because we're saying we believe everyone can have this, not just if you're a Native American or a Native Hawaiian. So
Yeah.
it's a little bit very much new breaking ground.
Okay, thank you. Thank you for your leadership.
Any other questions? One quick question. I have seen on the news that people are needing to re-sign up for Medicaid. How's that going? Is it going smooth, and do you need any help from the legislature?
Thank you for that offer. I think it's going relatively smoothly, that we've gotten really good feedback that the pink letter campaign has been helpful, because community members are noticing, like, oh, you got your pink envelope, don't throw it away, you got to read it. And we learned something new, as does CMS, each month it seems, so we can tweak as we go. For example, we're really working on increasing what's called our ex parte rates. That's what we do and what we strive to do is renew people without having to bug them. So if we can do that on an ex parte basis, meaning we use available data sources first to check to see if somebody's still eligible, and if they are, then their pink letter is a great one. It just says, dear so-and-so, you've been renewed using the following information. Let us know if anything's wrong, but other than that, you're good to go. Stay well, stay covered. Only those people who we try to use existing data bumps and we can't, those are the ones that get renewal letters saying, hey, we need a little bit more information. So we have been successful in increasing our ex parte rates as we've moved along by making little adjustments in our system.
Thank you. Anything else, members? Thank you so much. Really appreciate you.
Thanks to all of you for your help.
Thank you. Next up, I don't see the Executive Office on Aging
Yeah, they left.
was here. They left. So I've got, Mac, I was wondering if we can start with Utah Senator Kurt Bramble, because I want to wait for Tanoi Reed to come back, and maybe you and him can both come up. Can we take Senator Bramble out of order and have him come up first?
I think it'd probably be a good idea, Representative, if you have Mac lay the foundation with the scientific evidence, then I follow that.
We'll do that. Did you want to kind of look for Tanoi Reed?
Yeah, he's coming back. He just went out to the restroom.
Oh, okay. Come on up, Mac.
Hey, I see that you don't have those materials. Let me grab them real quick.
Oh, yeah. May stepped out of the room. She was going to hand it to us. Mac has been with a lot of the conferences, CSG, NCSL, and so he's worked with various state legislatures in the past.
Thanks to each of you for allowing us the opportunity to present on kratom. One of the first questions that I get when I appear before legislative groups is, what is kratom? And I have a unique actual prop that I want to show you that came from the island of Hawai'i. I picked them up yesterday. Let me just show you, you can take a look at it. Those are kratom leaves.
Wow.
Kratom typically comes from Southeast Asia. They're grown in Malaysia, Thailand, Indonesia. For centuries have been safely used there. The recent migration of kratom to Hawaii is because of the unique climate and soil conditions here. You currently have about 1,500 trees that are growing on Kauai. There, I'm told, a significant number equivalent on the big island of Hawaii, and that some are being grown on Oahu and in Maui. So it's a tremendous opportunity when you look at the population of kratom consumers in the United States, which total about 15 million people, and that roughly breaks down into a third use it like you would as a replacement of a cup of coffee for increased energy and increased focus. At a little higher dose, people are using it to mitigate feelings of anxiety and depression symptoms. And then at higher doses, people are finding success in weaning off of opioids and managing acute and chronic pain. The average kratom consumer is someone like me, my age-related chronic pain that you have to deal with, and people are finding very good success with it. And then, of course, across the age spectrum, you see great success. If I were going to break down three main points that I would like you to think about, first is kratom cannot be scheduled under the current science that's available today. You can Google kratom, probably the worst thing, I wouldn't recommend it, but when you do, you'll find out that the US FDA is against kratom. They want it scheduled. They have tried 3 times in order to do it. The first was in 2016. The Drug Enforcement Administration rejected it, saying insufficient evidence to meet the criteria set up by the Controlled Substances Act. They did a more complete scientific review and submitted it in 2018 through the Department of Health and Human Services, and it went to the DEA. The Assistant Secretary for Health, Dr. Brett Giroir, at the HHS reviewed the application and withdrew it in what by any definition is a scathing rebuttal of what the FDA had presented. And you'll find that letter actually under tab 1, where he indicated there was insufficient science, contradictory evidence being provided by experts in the field, scientists, and that the risk to the overall public health had not been adequately considered by the FDA. That is true today, by the way. They tried a third time. They went to the UN Commission on Narcotic Drugs, of which the United States is a treaty partner, at a lower standard for international scheduling and tried to get kratom scheduled there. On December 1st of 2021, the Expert Committee on Drug Dependence, comprised of 12 international independent experts on substance abuse and addiction recovery, rejected the FDA's and the global input about scheduling kratom at the international level, even at the lower level, and said there was insufficient evidence in order to justify that action. Had they done so, we would have been compelled under the treaty to proceed with scheduling of kratom at that time. It would have put millions of people, by Dr. Giroir's assessment, at risk for public health because people are using kratom to manage acute and chronic pain, and without it, they would be forced into more dangerous products and highly addictive products and potentially contribute to the overdose death crisis that we're facing today. And consider that 107,000 people died from overdoses. Opioid overdoses comprise about 70,000 of those individuals. People are looking for alternatives. If you look at tab 2, it is an infographic on a study that was done by Johns Hopkins University of about 2,000 kratom users who were using kratom in order to wean off of opioid addictions and to manage their acute and chronic pain. 87% of those individuals reported that kratom helped reduce their withdrawal symptoms, and anyone that understands the addiction crisis that we're in knows that that's the hardest part of getting off an opioid is the withdrawal symptoms that accompany that withdrawal. And then 35% were found to have completely replaced opioids with kratom within a year. Those are significant statistics, and why, as you'll see in the presenting material, the supporting conclusion that science doesn't dictate a scheduling is the director of the National Institute on Drug Abuse, Nora Volkow, has testified before the Congress that kratom should be available as a harm reduction tool in order to help people that are actually struggling with these issues of acute and chronic pain, and that's why it's so important. Other science, largely funded by the National Institute on Drug Abuse, and which has been approved and encouraged by the United States Congress in report language in the appropriations bill for increased funding of that research, has found that people are using kratom effectively in order to wean off opioids, that it is not dangerously addictive. You can become dependent, just like you can on the world's most used drug throughout the world, in caffeine. You can become dependent on it. You have to manage it carefully and obviously use it responsibly. But you don't have the problems that are associated with the other kinds of opioids that are the signature effects that come with it. The kratom hits the mu opioid receptors in the brain, but it's called a partial agonist activity, which means it doesn't go to the sector of the brain that drives these euphoric highs and the cravings that come with addiction, nor does it go to the respiratory suppression area. That's why you don't have overdoses on kratom, and why science has concluded that you are more than 1,000 times more likely to overdose on an opioid than you would on kratom. Again, you can abuse it, and certainly personality addictions are obviously more different than physical dependence or addictions that come with it, and those have to be carefully managed and supervised by a physician going forward in any of those situations. But the vast majority of kratom consumers are using it responsibly and safely. So the first 2 points: one, it can't be scheduled. Secondly, science should drive the public policy decisions about kratom. That's why 11 states have passed the Kratom Consumer Protection Act in order to put parameters around it, because that's the third point I want to leave with you, is that it has to be regulated. Currently, it is legal in all but 5 states. Initially, there were 6 states that banned kratom at the request of the FDA between 2012 and 2017. Vermont has withdrawn it. 4 of the other 5 states left are actively in the process of withdrawing those bans because bans do not work, and they were not justified by the science that the FDA was promoting, which Dr. Jawad called disappointingly poor evidence and data. Nothing has improved for the FDA since 2016 when they tried, and in fact, everything has improved with respect to science, showing that the safety profile and addiction liability of kratom is within acceptable limits and certainly is helping people as a harm reduction tool going forward. The point we make about regulation is that there's bad product out there because of the lack of regulations. Here's an example. This is a kratom product that is attributed to the death of a Florida woman. We hit the news here in the last couple of weeks. You may have read about it. $11.5 million settlement. The vendor didn't show up to defend themselves in court. This is their product. It is a pouch with kratom, by their marketing material said, a powerful kratom extract, meaning it probably wasn't manufactured according to FDA standards for food quality solvents to create an extract. But look at the labeling. There isn't any. And someone scrawled with a Sharpie space dust on the front of this package. This is why you should have regulation on kratom, and why it is essential that hopefully Hawaii will follow the 11 other states that have already passed the Kratom Consumer Protection Act. When I visited Kauai and see Hawaii grown kratom, I also got to see their packaging. This is a well-manufactured, well-packaged, and labeled product that is sold in Hawaii. It is one of the responsible vendors in the kratom space. There are probably 8,000 kratom vendors in the United States. There are probably 3 dozen, maybe fewer, who responsibly market kratom today that adequately label the product. That's why they have to be compelled to do so. That is why it is essential that we protect consumers when it comes to these products. We don't allow pain medications to be marketed without labeling for instructions for use. How much should you take? Nor should the people of Hawaii be subject to that kind of disinformation or lack of labeling by irresponsible kratom manufacturers. We at the American Kratom Association have established a good manufacturing program, and vendors voluntarily subscribe to it. They have to meet FDA standards for botanical supplement manufacturing, labeling, we just added that into our program, and all have to be subject to an independent third-party audit in order to verify that they're actually complying with those statutes. That's an important first step. But we've referred more than 75 kratom manufacturers in the United States because we represent the consumers, not the vendors. We referred 75 who violate federal law in impermissible claims about kratom, saying if you buy kratom, you'll do all these wonderful things, which are not allowed by the law unless you can prove it with good scientific evidence, and you have to go through the FDA process to do it. 75 of the last 3 years, kratom manufacturers referred to the FDA who complain that kratom is being used to self-medicate. Well, that's what those bad actors are using their labeling to do, is to compel people to over-medicate with kratom. Not a single prosecution in that 3-year period. The FDA is not interested in protecting the American people yet. Now, federal legislation is going to be filed here in the next couple of weeks that will compel them to do so, and it will mirror largely what the 11 states have done so far, and hopefully Hawaii will join them along the way. It is critical that we get to the point where good manufacturing practices and good labeling practices are in effect. This is the example of the Hawaii kratom, which gives specific directions on how much you should use, how frequently you should take it, and what the serving size is. Products like this need to be on the marketplace, not the space dust that I showed you earlier. Bottom line is that kratom, responsibly used, is a safe product. It is, as Nora Volko, the director of NIDA, said, is a lifeline. It is a harm reduction tool that should be available to Americans, not blocked by the FDA. And the U.S. Congress agrees with that, HHS agrees with that, the Expert Committee on Drug Dependence agrees with that, and the lone wolf in the forest out there is the FDA, and unfortunately they happen to be wrong. Just as they were wrong on dietary supplements, in 1994 the Congress had to act, and in acting they passed the Dietary Supplement Health and Education Act. And in that, they said that the FDA could not try to ban dietary supplements, which was their proposal, mirroring what they're doing to kratom today, because they don't like it. They wanted all of those dietary supplements to go through the new drug application process to be chemically formulated so that they could go through prescription only and only available, and of course at a high cost, through your physician. We know today that the dietary supplement industry is a robust $100 billion industry in America today, and 80% of the American people show their acceptance by purchasing and using those kind of products. The FDA opposes them today, just as they oppose kratom, and that's why we need the Federal Kratom Consumer Protection Act to open up that marketplace. You're going to hear from Senator Bramble and Twane the truth about kratom, and certainly we'll answer any questions when they're done with that presentation. So thank you very much.
Thank you. And Mac is a former representative, so thank you so much.
When I was young. So I'm a recovering politician.
There's
so.
no doubt we have questions.
No worries.
So we're going to come up. We wanted to hear Tanoi Reed, who, can we hear Tanoi first? The members, now, we're very fortunate. Tanoi he's an actor, a stuntman, related to The Rock.
I don't like speaking, but I'm a stuntman for Dwayne Johnson.
Related to The Rock. Yes. And he's on that great commercial, the Rock commercial. They call him the Rock guy.
Big
right?
Rock, the Rock guy, yeah.
But thank you for being here, along with Senator and Mac. What can you tell us about kratom as a consumer?
Thank you, Chair. Like I said, I'm not much of a speaker. That's why I do the stunts. But I came here because I have recently was introduced to Mac through a mutual friend, and I heard about this opportunity to speak as a consumer and supplementing with kratom for the last 5 years. So I'm here to explain my personal relationship with it and how it's helped friends and family as well over the last 5 years. So like I said, I've been a stuntman for 30 years. I've been doubling Dwayne Johnson for 22 years. Have my share of bumps, bruises, sprains, surgeries. No stranger to opioids. The doctors give you bottles, fix this. And it's kind of like a stuntman's secret. We used to keep a bottle of Vicodin or something, oxycodone in our bag, stunt bag. So if we twist the ankle, pop a couple, we're back in the game again. And this is called the problem. A lot of stuntmen and stunt women have been dependent on that to get through work. Just as you heard the stories earlier about people having to go to heroin because they have to go back to work and deal with the pain. This has been a huge issue, and with a lot of stunt friends of mine, and as well as where I live on the North Shore of Oahu, a lot of professional surfers. Andy Irons passed away from opioid addiction. It hit the North Shore, this epidemic over there. It seemed to calm down recently, and because I know a lot of them have discovered kratom itself. So the first time I ever tried kratom was in 2018. It was during my son's graduation party. And I was really having a hard time. I had some friends come from California to help me out, but they weren't helping me out. They're out at the beach swimming and everything. So I'm putting all the lights up on the tents and doing all this stuff. My back is killing me. I was in a grumpy mood, and I was like sore, and I was just complaining, and I think I dropped something, and I was swearing, and I just wasn't feeling it. And a friend of mine, one of the stunt guys, comes over and goes, "Hey, come here. Are you okay?" I'm like, I'm sore. I'm frustrated. He goes, "Here, I got something for you. Try this." And it was 2 green tea capsules. So this is called kratom. So I took them, drank my water, I go back up there, I'm doing stuff. All of a sudden, I feel this, everything's gonna be okay. It was a very subtle, positive energy, and my pain was gone. Like the back pain was gone. And I just felt, wow. And I carried on, finished the whole job, felt great. I'm like, what is this? So I started, looking into it, and I watched a documentary called A Leaf of Faith, which was produced by Chris Bell. I think it's on Netflix still, but you can find it on other platforms. And it kind of breaks down the whole history about kratom. And before you can only find it in like head shops. That's why it got a bad connotation. It's like, oh, it's a weed thing, it's a drug thing. It's nothing like that at all. Look at me, I'm epitome of health. I take care of my body. I want to live long. Everything I do is researched, and I have not experienced any negative side effects from kratom over the last 5 years. Let's see. Recently, I had surgery on my knee in February. I tore my patella tendon off. So before kratom, I had another surgery, my MCL. The doctor gave me Vicodin after the surgery. Post-surgery, that whole 2 weeks, I was taking the Vicodin, the oxycodones. I was on my bed or the couch, just sitting there doing nothing. Non-productive. I felt like crap. I felt woozy. Take another one. I didn't feel the pain as much, but I wasn't living. I was just sitting there getting through the day, and it was like Groundhog's Day every day. When I had my recent surgery, I had kratom. I didn't take the opioids, I took the kratom. I sit there on the couch, I'd get up, I'd be more productive. I was going outside, I was doing things, I felt more positive. The pain was gone, same pain management and everything. So it was I just threw the opioids away. So that was my most recent comparison to opioids with kratom. In 2019, this is how it helped my mom and my stepdad. 2019, my stepdad was diagnosed with a really severe form of leukemia. They live in Oregon, and they're one of the 6 states that has death with dignity. And he was not gonna get better, and they knew he was gonna go, and it was a matter of time. So we flew there to be with him for the last week, and the doctor gave him morphine, liquid morphine, drops in the mouth. And when I went to see him, he was so doped up on morphine, he didn't know I was there. Slobbering on the side, he'd get up, he'd throw up, it was terrible, but this is what they gave him to get to the last days of his life. I sat there watching this, like, I can't do this. I broke out my kratom, I said, let's try this instead. Gave it to him. The next morning, he woke up, the opioids were out of his system. He was cognitive. He's like, Tanoa, you're here. They helped with his pain. His hands were all swollen from the disease and everything. His blood, everything was going wrong, and he was in so much pain. He brought the pain down to a level where he can talk, and he was happy, and he stopped doing the morphine and took the kratom till the day the doctor came to help him pass. And he was able to live the last couple of days aware and cognitive and without the pain. So to me, that was a huge testimony of how it can help change lives. I definitely believe that this is la'au lapahau. You know what I mean? It is a medicinal plant that was put on this earth for a purpose. Imagine there's a cocaine addict, a crack addict, and you can get them off their addiction with a certain kind of coffee or a strong espresso, and it feeds their whatever they need, and that's all they need. It's natural. So this is the equivalent of that to me. That's all I got to share for now. Any questions?
We're probably going to have a few,
yes.
Tanoi, but thank you for representing the 808 state greatly, and thank you for your testimony. We may have a couple questions after we talk to Senator Bramble after his presentation. But again, thank you for being here.
Thank you. Thank you for having me.
Okay.
All righty.
Senator Bramble, thank you for coming from Utah. I understand you're going to be at the NCSL Summit, so we'll see you there again. But thank you for being here.
I will be. And thank you for this opportunity.
So we as legislators have been fighting, I've been in the Senate now for 23 years. For 23 years, we've been fighting the war on drugs. In Utah, we have a controlled substance database where it's mandatory that physicians check the database before they can prescribe opioids. The pharmacist has to check the database. We are trying to find every tool we can to effectively deal with opioid addiction. And yet, I was testifying in Louisiana a few weeks ago, and I testified that 11 citizens die.
One every 11 minutes.
One citizen dies once every 11 minutes. Former drug czar for the White House corrected me, said, "No, Senator, that's not right." Today, the statistics are one person dies every 6 to 7 minutes in the United States from a drug overdose. Now, the statistics Matt gave, 70,000 roughly, that's about one person every 8 minutes. The reality is folks are dying from opioid overdose, and how are we dealing with it? Naloxone, buprenorphine, we have pain clinics, whatever. About 5 years ago now, I was introduced to kratom as a policy matter. Kratom is a plant that has never been illegal in Hawaii. It's grown in Hawaii. It's not scheduled. It's not scheduled in 44 states, Utah being one of those states. When I first looked into kratom, Googled it, and I found the FDA said that it was a dangerous narcotic, that it was an opioid, that people died, and it should be banned. I then did a deep dive, and I found that the FDA was plain and simply wrong. The data they looked at, they said it started out with 9 people that died from taking kratom. And that's true, 9 people died after taking kratom. The toxicology reports indicated that all 9 people died from a tramadol, synthetic tramadol, O-desmethyl tramadol. The kratom had been laced with tramadol. All 9 people bought it from the same online distributor. It was a product called Krypton. The FDA then doubled down. They said, well, we found another 44 deaths. Every one of those deaths, including one toxicology report that they redacted all of the information, every one of those showed poly drug use in significant concentrations to cause the death. It was that 44th, though, that triggered my real curiosity. That 44th death, they had everything redacted except the date of death, name of the decedent, and the cause of death was kratom. When we finally got the unredacted copy, and this is something that we can provide you a copy of the unredacted report. The individual had multiple chemicals in his system. That was redacted. It was called a kratom death. Multiple gunshot wounds to the chest. That was redacted, and it was called a kratom death. It turns out it was a drug sting. It was law enforcement that in a shootout, he died in a shootout with a drug sting with law enforcement, but it was all redacted, and it was called a kratom death. That single event, when I was provided that information, I decided I needed to do a much deeper dive. In the last 4 years, I've been to Indonesia multiple times. 95% of the world's supply comes from the West Kalimantan region of Borneo. You have a kratom plantation here that apparently produces very high quality kratom. So why do we need legislation? Well, the problem is bad actors are adulterating kratom. There is no euphoric high, there is no respiratory depression, there is no mental impairment. And as you've heard, the risk of addiction is about like caffeine. Bad actors in the drug culture want to have kratom give a kick. So they lace it with fentanyl, they lace it with morphine, they lace it with benzodiazepine, Valium, they lace it with whatever narcotic or whatever drug they can to give you a kick, and then they market it that it will give you a high. We want to stamp out those bad actors. So in Utah, we passed the Kratom Consumer Protection Act. What does it do? It simply says that kratom, Senator, you have a bottle of water in front of you. That bottle of water, if you pick it up and look at it, it has a code on it. It is regulated. It's required to have a label that says what the content is, if it has minerals, whatever, and there's a batch number, and you can track back if there's a recall on that bottle of water. That's all we did with kratom. We just said it has to have an independent lab certificate of analysis for the product. The product has to be registered with the state, or the manufacturer has to register their products with the state, and it has to be properly labeled. Now, why would I be involved? We have 6 children. I've been married going on 46 years. We have 20 grandchildren. We have a daughter and son-in-law that both high school athletes. They were premier athletes, both recruited by colleges. Matter of fact, our daughter's boyfriend, high school boyfriend, who became our son-in-law, was one of the top football recruits in the nation, a linebacker. But they'd both injured themselves in high school. They were on prescription pain meds. That led to prescription abuse. One thing led to another. They were eventually picked up on heroin charges, spent some time in jail. My son-in-law died of an opioid overdose. Had I known about Kratom and the potential for this plant, we might have avoided a death. I want to share with you 2 situations that I've kept with me that encapsulate why this is a legislative issue. Saving lives and providing the tools to effectively fight the opioid crisis is critical. This first one came from an individual, unsolicited, and I joked with Representative Mizuno. I was given a promotion to Representative Bramble from being a senator.
I thought that was a demotion, but he said it was a promotion. So.
Anyhow, Representative Bramble, I understand you have been, and I'm going to read it verbatim, I understand you've been supportive of some legislation around the regulation and legal parameters around Kratom. Thank you for being willing to be informed. I was on prescription opioids for over 5 years, completely dependent from what started out as chronic pain. I tried to gradually wean myself, but when I eventually stopped completely, the withdrawal symptoms were simply unbearable. Kratom was killing me. Opioids were killing me. Kratom allowed me to continue my efforts to be completely free of opioids. I haven't taken a pill for over 2 years. What a blessing. Kratom saved my life. The second email that I received was a little more personal for me. When I ran the legislation in Utah, Representative Brad Daw was my House sponsor of, I can't remember, Senate Bill, I can't remember the number. Anyhow, I was the chief sponsor of the Kratom Consumer Protection Act, and my House sponsor, Representative Brad Daw, his wife is an accomplished nurse, master's degree, nurse leader, very prominent in the nursing community in Utah. She developed breast cancer, and as a result of the breast cancer, in her emails, she said that she developed as a, well, let me read this. Kratom powder has given me hope that I thought I had vanished for living a pain-free, healthy lifestyle again. Chronic pain has never been something I thought I would experience firsthand. My healthy, active lifestyle came to a screeching stop with cancer. Ensuing treatment, secondary chemotherapy-caused diagnoses, frequent migraine headaches, complex regional pain syndrome, and arthritis became my familiar companions. She goes on to talk about how her life was being destroyed by drugs and opioids. She then, and it's a really long email, so I won't read it all verbatim, but the gist of it is, she thought that Kratom was an elixir, a snake oil, it was hocus pocus, bogus, that there was no validity to it, because she was trained in the traditional Western medical arena of only prescription drugs were viable. So she didn't oppose us running the bill, but she said that it was a placebo, that it wasn't very effective. 2 years later, Representative Daw called me, and he said, Kurt, Laura is at the end of her rope. The depression, the opioids, they are killing her. She's not able to function. She has finally decided, as a last resort, she's tried everything. And in her email, she says, after regimens of injections, a huge variety of medications, many with unacceptable side effects, comprehensive traditional and non-traditional medical treatments, pain clinics, physical therapy, and even cannabis trials, each failed one by one, I came to terms with the fact that my life would be laced with discomfort, depression, and pain every day. The pain I endure is physical, but the effects take a high toll on my emotional sense of well-being and have removed any joy I find from life. I mostly came to terms with this new lifestyle reality. Then she was on to say I was given a chance to try Kratom. She very carefully measured out exactly 2 grams, and she took it. Before she took it, in her notes, she said, my pain was at a 9 or a 10, completely debilitating, unable to function due to the pain. And had she taken opioids, that would have given her a drug-induced stupor that would have not allowed her to function. She said, I measured out 2 grams, I took kratom. After about 10 minutes, I had a sense of well-being, not a mental impairment, not an intoxication, but just a sense of well-being, kind of what you just heard testimony of. She said, but my pain, the biggest issue was my pain was reduced from a 9 or a 10 to a 1 or a 2 and became completely manageable. In my skepticism, she says, I thought it was just psychologic. She said, but those effects lasted for about 4 hours. After 4 hours, the pain gradually came back to its original intensity. She said, I thought it was just psychologic, and so I waited a couple more hours. I then took kratom again, and I experienced exactly the same relief that I thought impossible to find. Today, Laura Daw, medical nurse, a registered nurse in the medical arena, will tell you that kratom has saved her life as well. During my travels over the last 4 years, I've received literally a myriad, a plethora, I don't know, hundreds or over 1,000 emails from individuals who have given anecdotal testimony that kratom has saved their life. So if we're really going to be effective on the war on drugs, you heard from departments, from agencies, from pain clinics, from addiction recovery centers. There's John, John Shinholzer. I've actually interacted with him at national meetings, runs an addiction recovery center. He was using naloxone, buprenorphine, and et cetera. He's changed to kratom, and he's had a phenomenal success result, a percentage of success in his clients getting past the opioid addiction simply by using this plant from Indonesia. So I'd encourage you to seriously consider looking that kratom is legal in Hawaii. Why should you regulate it? Because we want to go after the bad actors. If we don't, the FDA is trying to prove that kratom is dangerous. Well, I don't know if you guys saw the report. Just recently, a 30-some-year-old woman died from drinking too much water. Quite literally, she died from drinking too much water. It caused an electrolyte imbalance, and her cells swelled up, and she died. I had that happen with a 13-year-old in my district. This girl, young lady, her parents were disciplining her by forcing her to drink water. Well, we don't ban water because 1 or 2 people have died. We simply say, look, there are certain times you don't take water in excess, or it could be potentially dangerous. Well, kratom, even if you take it in excess, the science, the National Institute of Drug Abuse, the actual addiction scientists will tell you that if you consume too much kratom, what will happen to your system? You'll vomit, you'll expel it. It doesn't give you an overdose. There has not been one recorded fatality where it has been irrefutably documented. There have been anecdotal stories saying a death was the result of kratom. The toxicology reports, the autopsies have not supported that. And in my travels throughout the world, we've not been able to document not even one fatality purely from kratom. So that's why we're here, to try to help advocate for a tool that can really be an effective alternative. If we continue doing the same thing that we've always done, you get the same thing we've always got. And someone once said that that's a definition of insanity. We have to find innovative ways to effectively deal with opioid addiction and the war on drugs, and kratom can be one of those very effective tools. So thank you.
Can you stay there,
Sure.
Senator?
Sure.
We have only 2 last presenters, but I know this is very important for Chair Bellotti, who chairs the Health Committee, and Senator San Buenaventura, who chairs the Health and Human Services Committee on the Senate side. If they were hypothetically to introduce the Kratom Consumer Protection Act for Hawaii, the question is that we need to tell our colleagues as 2 things, as this bill is introduced and if it's to move along, would be, in addition to 11 states already passing that, if there's already federal legislation that appears to be close to passage, a lot of our colleagues may ask, what's going to be national policy? Why would we need to do that?
Because the probability of getting something passed in Congress today, look, you and I have worked together closely at NCSL on various policies. NCSL is bipartisan. Every committee has a Republican and a Democrat. And at NCSL and at the state level, I look at your Senate President, Senator Cucci. He and Joy are good friends. Speaker Psyche followed me as president of NCSL. We're a very conservative state in Utah. We have about as high a percentage, actually not quite as high a percentage Republican majority as you have Democrat majority here in Hawaii. And yet we're Americans first and foremost, and we look for solutions. Unfortunately, that's not the game in Washington, D.C. So while legislation is introduced, what we're trying to do at the state level, and there is no comparison between kratom and marijuana in terms of its pharmacology. Marijuana is banned federally. It's still illegal technically on the books federally. But when the federal government fails to act, it's incumbent upon the states to take up the issues. Not only have 11 states passed the Kratom Consumer Protection Act, there are some 30 that are currently, they're in the process of deliberating. Of those 6 states that ban kratom, 5 out of the 6 are replacing it with the Kratom Consumer Protection Act, because in the absence of federal legislation, we never would have either medicinal marijuana or in those states that have recreational. And I personally, I'm not an advocate for recreational marijuana. I supported medicinal use for marijuana in clinical situations, but then marijuana, it clearly has mental impairment. There are other aspects of marijuana that we don't see with kratom. But had the states not acted, we wouldn't be where we're at. And that happens time and time and time again when the federal government fails to act. So yes, there is legislation being introduced, but it's been introduced at least in the House previously, and it's been talked about previously, but relying or waiting for the federal government, in the meantime, the risk is that if you don't aggressively challenge the idea that adulterated product is on the market, the pictures you saw of space dust, that will simply give the FDA the kind of misinformation campaign that ultimately may succeed in banning kratom. That's the challenge.
Right, and I think we like what Mac Haddo had mentioned, that this is a consumer protection issue. It's a quality control issue. So you want kratom products to be tested.
Well, you want your consumers to have confidence that they know what they're buying. That's why I used the example with the senator of the bottle of water she had in front of us. You can't buy over the counter a bottle of water in Hawaii today that's not regulated. Why? Because we don't want tainted water being sold.
Oh, thank you. Thank you very much. I'm going to have Tano, if you can just 1 minute, come on up and show us some of the products that you use. Okay. And Mac, anything else to add before we move on to the...
Well, just show you the products I received from the Hawaii group, which fabulous, like I said.
Do you think this could be an economic driver for the state of Hawaii?
Hey,
no question.
Representative?
Can Representative Belatti and I take this home?
No.
Look, 4 years ago...
I will go purchase it on my own if I can.
Well, that's a very good question, though, because 4 years ago, we were told that science, they didn't believe that kratom could be effectively grown within the territorial bounds of the United States because of soil, because of conditions, that it was indigenous to Southeast Asia, but very difficult to grow anywhere in the United States.
And Hawaii is just growing it like...
Well, Hawaii, you have a great kratom producer here. Yes, it has a huge, huge potential. Those areas where you used to have pineapple plantations or whatever, kratom could be a very valuable tool.
I would think Hawaii would want us to pass a bill like this to protect them and their products.
So this particular group in Hawaii are doing plant genetics. I mean, they're experts in plant genetics, and what they've done is looked at each of the areas in the Hawaiian Islands where they can grow. They've seen it grow virtually everywhere. There's some areas where it's too arid in one of the islands, but wherever you've got rain coming, they can grow this, and the soil conditions and climate conditions are ideal. So look at the economic potential. We're importing into the United States 5,000 metric tons of kratom a month. If the island of Kauai and the rest of the islands here in Hawaii can can start to contribute to that and get to, with 1 million trees, you're probably looking at somewhere in the neighborhood of 300 to 3,000 to 4,000 metric tons per month. You're going to replace what's happening in Southeast Asia, a $1.3 billion industry today, and once the federal legislation gets through, it'll explode. It'll be much, much bigger than that. So great economic opportunity, no
I'm
question.
looking at Senator Bramble with the federal legislation and
Well, one other thing I would add to what Senator Bramble said, these states are empowering their congressional delegations to also say, let's do the right thing here, and we get a critical mass of states doing it, then it'll sail through the Congress, but we need to get the states to do it first.
right. Thanks. Tano, you wanted to share with us some of your products.
Yeah, these come from a reputable company based out of Las Vegas. If you watch the documentary A Leap of Faith, it highlights this company and the owner of it, founder of it. These are blister pack samples you can use, but like I said, the one that has turmeric and melatonin to help you sleep, along with the kratom. The one has caffeine in the morning to help you get going. And then there's some other just different strains. It's like other, you have green tea, red tea, white tea, different strains of kratom itself. Like I said, it's like taking a cup of coffee in the morning. What that does for your alertness, this does for your pain and well-being. It's not like smoking marijuana, medical marijuana, you get high, you can still function, drive, everything completely fine. But your pain is gone and the sense of well-being is definitely there.
Tano, what is the cost approximately for a packet?
I'm not sure about these because these are the samples that he gave me to hand out to anybody who wants to try them. But I do have the bottles. There's a bottle of tea caps that I have, and I also have the powder as well. Like I'll put a scoop in my coffee in the morning. Anywhere, depends on the size. The pills can go from $35 to $50 depending on how many pills are in there as well. Yeah.
You know, Representative,
Yes.
you can actually go online, and there are several reputable kratom distributors. I'm not trying to give a pitch for any, but there is
We
one.
look for the states that regulate this.
Well,
right?
what you do is you look for the not just the states that regulate it, but you look for those distributors or those manufacturers who are meeting the GNP standards of the American Kratom Association, because they've established the manufacturing standards and the testing standards and the certificate of analysis standards necessary to know what the product is. But I'll give you an example of one out of Texas that I just happen to know, New Wave Botanicals. So if you want to find out what the market cost of kratom is, you can go online, and if you look, I think AKA, you guys actually publish the list of your vendors that are, or the manufacturers that are.
The ones in the GMP list are up on our website.
So
Yes.
that would be considered the
So
safe
you
list.
you can look at the ones
They're
that are,
vetted. Yeah, they're
the ones that
tested.
AKA have certified, then you can go to their websites. That'll give you an idea of what the market is.
Okay, Chair Bellotti, anything else?
I have just one question, and probably it's for the senator. I knew very little to nothing about kratom before this presentation, so thank you to all of you.
Well, hey, I knew nothing about it till Mac asked me if I'd run legislation in 2018. My first reaction to him was no, because I saw what the FDA said about it, and look where I'm at today.
So what I'm curious about is, because I know that, well, I don't know much about it. I've heard little bits and pieces about it, and like it, they pop up in these smoke shops. When these states, these 11 states enacted this legislation, did they see product being removed, like bad product actually being removed from their states? And does the act provide legislation to impose standards that can then be enforced by, say, state regulators to pull bad product out?
Absolutely.
Okay.
In Utah, what we did, and various states do it a little, there's variations on which department. Department of Health. In Utah, it's the Department of Agriculture. Some states, it may be the Consumer Protection. But yes, it eliminated we have found in follow-up with Public Safety and our Department of Agriculture, through working with AKA, filing complaints with the FDA against bad actors or whatever, those products have come off the market. As a matter of fact, our Department of Agriculture, they've actually removed some products based on them not meeting the criteria. And the positive thing from a legislative fiscal point of view is the cost of the registration or the cost of enforcement is borne by the fees paid for registration and administering the program. In other words, it's paid for by the industry. It's not put a burden on taxpayers.
Thank you. That's the only question I have.
So
Chair.
the answer is yes. We followed up with our Department of Public Safety. 3 years, about 6 months ago, I talked with our Commissioner of Public Safety, Superintendent of the Highway Patrol, head of the Sheriff's Association, head of the various health departments, the State Department of Health and the county departments of health. And we have not seen any abuse of kratom since we passed the, we've seen some products that have been pulled, but we've not had complaints of tainted product being out in the marketplace as a direct result of the KCPA being the law.
Thank you.
Thank you.
Thanks, Chair.
Thank you. I've got 2 more testifiers here, but are you guys going to be around for a few minutes?
Sure.
Okay, we should be in no more than 10 minutes.
Yeah.
Donald, thank you. Okay, so next up, I believe they're going to be on Zoom. Is that correct? I've got Dr. Moore, Dr. Jacqueline Moore. We just, Senator Representative Bellotti did a great job. We had a site visit to their dispensary, so I thought it would be prudent to have her here, talk about medical cannabis. She could not make it, so she has Dr. Craig Pollard that will be in her stead, so. He's up.
Yeah, aloha, committee chairs, vice
Thanks
chairs.
for being here.
Absolutely, thanks so much for having me. So I would just like to take a moment to share that my thoughts are with all members that are from and the people of Maui during this difficult time. But thank you for the opportunity to speak here today. I'm extremely passionate about this subject matter, having worked as a community pharmacist here in Hawaii for most of my professional career. So my name is Dr. Craig Pollard. I received my doctorate of pharmacy from Rutgers University, and I'm currently working as Senior Director of Production for Big Island Grown, one of Hawaii's 8 medical cannabis licensees. A little background, I practiced community pharmacy in Hawaii for almost 10 years. Most of those years at a community pharmacy in a small town on the Big Island. Want to get a great understanding of how bad the opioid epidemic is here in Hawaii? Ask your local pharmacist. We see patients from all walks of life day in and day out. Want to know how bad this affects individual communities? Ask a pharmacist that has practiced in the same community for years. They know colleagues who have been robbed at gunpoint for these drugs. They have had to call EMS to attend to patients overdosing in their bathrooms. And sadly, they've filled prescriptions that have led to accidental overdose deaths. So let's dive into some of the stats. The Hawaii Opioid Initiative reports that there were over 150,000 opioid prescriptions filled in the state of Hawaii in the last quarter. That's over 600,000 opioid prescriptions that will be filled this year alone. And opioids are highly addictive, as we know, and can lead to long-term opioid use in as little as 5 days. So what can we do? What do we need to do? We need to responsibly reduce the amount of opioids that are dispensed and have viable alternatives presented to patients prior to their first opioid prescription being filled. How can we do it? Cannabinoids can help. From published studies, we know cannabinoids have multimodal mechanisms of action, producing analgesia, including modulation of neuronal nociceptive processing, inhibition of pro-inflammatory molecule release, inhibition of mast cell activation, and modulation of endogenous opioid receptors in primary afferent pathways. So what does that mean? Cannabinoids help with pain. So how do we get our chronic pain patients to ingest cannabinoids? One of the ways is to increase access to cannabis. And there's precedent for this. There's a variety of cohort studies from other states that reviewed their state prescription monitoring program data that show a reduction in the morphine milliequivalents of patients that are enrolled in the state's medical cannabis program versus control groups. New Mexico reviewed patient data from around 70 patients, about half of which were enrolled in their medical cannabis program. Medical cannabis program enrollment was associated with 17 times higher odds of ceasing opioid prescriptions, 5 times higher odds of reducing daily prescription opioid dosages, and a 47% reduction in daily opioid dosages, relative to a mean change of a positive 10% in the comparison group. New York State monitored their PMP from 2017 to 2019. Over 12,000 patients were included in this study, divided between the medical cannabis exposure group and the non-exposure group. During follow-up, significantly greater reductions in opioid dosage were observed among the exposure group. The daily morphine milli equivalent for the last month of follow-up among patients receiving medical cannabis was reduced by up to 48% compared with baseline dosages. And among individuals in the non-exposure group, the daily morphine milli equivalent was reduced by as little as 4%. Lastly, and much more anecdotally, I'm seeing cannabis help increase patients' quality of life. In the same community with those same patients who I dispensed opioid prescriptions to for years. One patient that comes to mind, a male in his early 50s. He was on over 120 morphine milli equivalents per day when I last saw him at the pharmacy. About 2 years later, I ran into him at the local farmer's market, and he came right up to me to say, "Thank you for what you're doing." Of course, I asked him if he had been to the dispensary, and to that he replied, "Been there. That's all I use for my pain now. I'm completely off pain pills." I couldn't believe it. I mean, I knew cannabis could help, but for a patient on these doses to now be opioid free, incredible. Beyond my wildest dreams of what could be possible, but exactly the reason I took the leap into the world of cannabis. I do want to personally thank the members present today that were responsible for passing our medical cannabis dispensary law in 2015 so that stories like the one I just shared are even possible in our state. Okay, so let's talk barriers. Cannabis as an alternative therapy is not covered by insurance, between doctor's appointments to medication costs to registration. A consideration, is medical cannabis treated as a medicine or as an illicit drug in our state medical system during a medication reconciliation at our hospitals? Patients have to go to special certifying providers and in some cases fear even informing their primary care providers. And the ultimate crux of the issue, it is still easier to get access to an opioid prescription in this state than it is clean, tested cannabis, and until that's not the case, there is work to be done. In short, we need a state-supported initiative advocating that cannabis should be considered as a viable alternative and adjunct to opioids and as a potential partner in helping to reduce overall opioid doses, which could lead to a reduction in opioid-related morbidity and mortality. I want to thank you guys for your time and attention. Again, I really appreciate the opportunity to speak here today. Please don't hesitate to reach out with any questions.
Thank you, Craig. Chair Bellotti, did you have any questions?
I don't think I do at the time, but thank you, Dr. Parlin, for joining us. And I just want to also say, we know that there were wildfires also on the Big Island, and so that's not been gone unnoticed by folks here at the legislature. And, you know, I think everyone is traumatized across the state. So
yes,
thank you for joining us and being so patient for this very long information.
Absolutely.
Right.
I appreciate your thoughts and the opportunity. Thank you.
Craig, and of course, Chair Bellotti led the site visit a couple weeks ago on the Big Island to your dispensary. Could you please let Dr. Jacqueline Moore know, give her our best. Hope she's feeling better, and thank you. And by the way, that was Chair Bellotti that led that movement to pass that bill back in 2015. She's too shy or humble to say anything, but Doctor, thank you so much. Appreciate you.
Yeah, thank you for those kind words, and Chair Bellotti, thank you so much for your work on that bill, and appreciate all you guys do.
Right, thanks again for the site visit. That was great. We're down to our last testifier. We've got Dr. Clifton Otto that contacted me, and so I think he's queued up on Zoom. So Dr. Otto, can you hear us?
Yes, I can. Can you hear me?
Yes, thank you for joining us. You saw the briefing notice, reached out. We're glad to have you here as a physician. Please do share your thoughts on access to safe alternatives to opioids.
Well, thank you. Good afternoon, chairs, vice chairs, members of the committees who may be watching remotely, and distinguished guests. Thank you for the opportunity to talk with you about fighting the opioid epidemic. My name is Dr. Clifton Otto. I'm a medical doctor in Hawaii, cannabinoid medicine specialist, and a certifying provider for Hawaii's medical cannabis program. My disclosures are that I have no association or commercial interests in any dispensary, patient co-op, or hemp company. I'll keep my comments very brief and focused on cannabis as a potential treatment for opioid use disorder. If I were a psychiatrist, I could hold up articles showing you that cannabis could lead to a higher risk of opioid abuse. And if I were a harm reduction specialist, I could show you articles on how cannabis is reducing opioid prescriptions and opioid-related deaths in states with medical and adult use cannabis programs. My point is that to consider cannabis as a possible treatment for opioid use disorder, we really need to be looking to healthcare providers with boots on the ground in Hawaii. I can tell you that I have registered patients who qualify under the severe pain category who are successfully using cannabis to maintain their take-home supply of methadone with their counselor's approval. I also have patients who become addicted to opioids after surgery who are able to completely wean themselves off of prescription painkillers using cannabis. And I have a local methadone clinic calling me wanting to refer patients because nothing else is working. You could also talk with other certifying providers in Hawaii, like Dr. Thomas Cook, who wrote the letter of support for the opioid use disorder petition that was denied by the Department of Health in 2019, and you will hear similar stories. The question is, how can we move forward with local research on this topic? The Office of Medical Cannabis Control and Regulation has a dedicated epidemiologist who could certainly help us look for signals by surveying registered patients who are already using cannabis to reduce opioid use, and they may have access to funding. We also have a University of Hawaii cannabis research program authorized under Chapter 304A of Hawaii Revised Statutes that could be utilized by the medical school to conduct an observational study on opioid use reduction in registered patients. And there is also the option of adding opioid use disorder as a qualifying condition to the Hawaii's medical cannabis program, either by repetitioning the department or by statutory amendment. I would only caution that in our efforts to fight the opioid epidemic using healthier alternatives such as cannabis, we should not end up substituting dangers of opioid addiction and interacting with the illicit opioid market with the devastating consequences that come along with patients having to violate federal law to participate in our state medical cannabis program. We need the governor to act on the federal situation with cannabis in Hawaii beyond simply waiting for Congress to remove cannabis from the Federal Controlled Substances Act. Those are my comments, and I welcome any questions. Thank you.
Thank you, Dr. Otto. Chairs, any questions?
I have one question.
Yes, Chair Bellotti.
Dr. Otto, thank you so much, and I know you've been a long time advocate in this space. Do you know if any medical cannabis program in the States has been able to add opioid use disorder as one of the qualifying conditions?
You know, actually, I would have to look into that. I don't follow the other state programs as closely as I do ours, of course. I would have to look into that, and I could get back to you on that.
And I know just because you're so like well-read and well-researched, do you know if there's any international studies or any medical studies that are looking at this specific issue of cannabis as an opioid use disorder alternative?
Well, there are several articles in the literature already that have documented that, and I'd be happy to send you links to those. So I think it's been well established that cannabis could possibly be a way for patients to get off of opioids and avoid opioid addiction. So I believe the next step is to put something together, do some type of research so that we could know what actually is going on in Hawaii and what the potential is for using cannabis to address the opioid epidemic.
Thank you, Doctor. Thank you, Chair.
Dr. Otto, we've got another question from Chair San Buenaventura.
Hello, Dr. Otto. So isn't relief from pain already one of the conditions that cannabis can be prescribed for?
Well, yes, exactly. And that was one of the reasons that was stated in the denial of the opioid use disorder petition in 2019. They said that patients have access under the severe pain category, but also under the severe nausea category, which patients experiencing when they're coming off of opioids. So that's why I was mentioning in my comments that there's probably already a lot of data available that we could research from registered patients to see how they're using cannabis and how they've been able to get themselves off of opioids.
Okay,
So,
it's just a
you know, if
question-
you're,
Sorry.
sorry.
So because it's already covered, it's just a question of educating the PCPs instead of cutting off patients, to be able to educate them on who to refer these patients to.
Well, I would say yes, education is definitely part of the puzzle, but I think we need to do some research on this. There's a lot of data that we need to look at to see what the prevalence of its use is in patients who are using this to treat their opioid use disorder already. I think that could be helpful to inform how the state wants to use, potentially use cannabis for this.
Okay, thank you, Dr. Otto.
Dr. Otto, when you email Chair Bellotti, could you also CC Chair San Buenaventura and myself?
Absolutely, I'd be happy to.
Thank you very much, Dr. Otto. Appreciate you. Before we
Thank you.
close, thanks, Doctor. Before we close, I'm going to work with the two chairs, encapsulate, I believe, everything we went over in about 2 minutes, hopefully. So let's kind of see what we've done. And again, what I'm going to do is try to send this out to both chairs as well as our communications directors to send out a press release once we agree on what we've got from this very outstanding informational briefing, all-star cast of presenters. So we've heard from the top pain management specialist in the state, Dr. Garcia, patients' right to pain management. We also heard it's a quality of life issue. Chronic pain is complex. We get that. We totally get that. Dr. Garcia pointed out there's no one treatment, and certain treatments may work for one of us, another treatment may not. But at the end of the day, I think the indication from presenters were the focus is on non-opioid treatments, alternatives such as physical therapy, acupuncture, massage therapy, chiropractic therapy, even Native Hawaiian healing techniques. They're actually asking for an 1115 Medicaid waiver to provide that. We've also talked about kratom being an alternative to opioids, as well as medical cannabis. What were some of the barriers? We understand that education is a barrier. The providers need to know more, as well as the patients. Coverage of health plans. That's, Chair Bellotti brought that up. Medicaid, what do you cover, what do you not cover? So again, a barrier could be my health plan does not cover certain alternatives to non-opioid treatment. So that's a barrier. And we heard from Heather, harm reduction, need to transition from opioids to these safe alternatives. So there's still a lot of work to be done. In emergency cases, Narcan or naloxone can be used. I'm really impressed with the kratom angle and why they're asking for us to do a bill, basically quality control, consumer protection, to make sure it's not laced with fentanyl or any bad drugs. We get that. We understand why you're here. Colleagues, please do add some things that I may have missed.
And
Senator?
the other thing is that the PCPs should not just cut off their opioid patients, but to do safe titration guidelines to wean them off safely instead of cutting them off.
That's a good point. And I believe, yeah, Heather did bring that up about the transition. It needs to be a soft landing for a lot of the patients. And I think, again, that therein lies the education of both the provider, the physician, and that patient.
Right.
Right. And Chair Bellotti, anything?
Maybe I would just add that one of the things for future exploration by both of our committees is follow up on the opioid settlement and how that's rolling
That's right.
out
Follow up.
counties, throughout the counties and statewide.
Yes.
Great.
Because it might actually help us achieve some of the education and research that we need to do, as well as address breaking down the barriers.
So I know Carmen from NCSL is going to be emailing us with that breakdown on what other states are using. So perhaps before the session, we can all have a cup of coffee or something and talk about who's going to be introducing what bills.
Or a cup of kratom tea.
Oh,
Yes.
a cup of kratom
Kratom
tea,
tea.
yes. Okay, anything else to add? Okay, well, with that said, members, can I adjourn this?
Yes, please.
We're adjourned, thank you.